So welcome to the capacity advancement session. We are also glad to inform you that currently we are offering 44 critical and underserved medical specialties under the capacity advancement program. This will include your respiratory medicine, which you truly take, acute medicine, cardiology, neonatal care, gastroenterology, infectious disease, internal medicine, and a lot more, neurosurgery, the list goes on. You can find a comprehensive list of all the specialties that they are offering right now. It's 44 in number in the mark.com. So you will see specialties, whether it's going to be on site or online. If you go through, you see them all. These courses are going to be provided through the universities of South Wales in UK. Then you have the University of Edinburgh is part of it now, University of Buckingham, the Queen's Mary University in London. Them are part of it. That's for the UK branch. And then if you also want Manipal University, is going to be in India. In that the university in India. We are also excited, like I mentioned, to announce that the new version of the Merck Foundation app is available at your Play Store and Google Play Store and Apple Store. You can download it so you can have timely information regarding the programs they are doing and all the activities involved in the Merck Foundation in general. Now we will start with our first speaker, who is well known in the Gambia already. He's a consultant in pediatrics, a fellow of the West African College of Physicians, a lecturer at the University of Gambia, and the founder of the Pediatric Association of the Gambia. He has played a pivotal role in strengthening pediatric healthcare and medical education through his leadership and expertise. He's very encouraging and he insists that everybody has to become a consultant. His topic today will be in pediatric prevention in the Gambia. He'll be giving you facts that you know and data that is collected within the Gambia itself. So you are having first-hand information on the healthcare system on pediatric level in the Gambia, challenges, solutions, and guidelines and treatments. He is no other than Dr. Makalo. Dr. Makalo, you're welcome.
Thank you very much, Dr. Tunkara, for the introduction. Good morning, everyone here. As I said, I have to stick to time and I know her very well. So I don't want to waste much time. Just to go into the presentation, it's a lengthy one. I don't want to leave certain, issues behind, but just decide to give as much as I can, and then I will also just give maybe try to summarize my slides, very well. So I think this is a very, very important topic for me. I think it's the first of its kind to somebody in the game. It's not much. It's not about pediatric conditions. Because the players were not new. You can see the country. Most of those our pioneers, most of them were practicing outside, FSTH, so they don't know most of the diseases that is emerging diseases in this country. So now it's time for me to highlight some of them. Yeah. So number one, I want to talk about malnutrition in the country. Yeah. It's a very, very important. Let's go to the slide number. So we'll talk about some of these diseases in the country. So next slide. Yeah. So as you can see from here, malnutrition Gambia has chief important state in this. From year 2000, you can see now the situation was very serious. But now you can see at 2025, we still have a lot of. So this information is based on slide, you can see the level of information from the earlier slide. As it can and see or even nowadays, we are even registering, obesity at 2%. And HIV also is another driver here. Among children, you can see in the Gambia, we have something like 1.7%. So because of the introduction of PMTC, you can see now it has reduced infections in pediatric population, which is also available to us. And now UNICEF has also introduced another program called Time Norm, where they are trying to reduce HIV infection, syphilis, and hepatitis B together. Because if you go to our antenatal clinics, they are doing those type of screenings, and I know that's also helping a lot. And it's doing Ghana what we're doing from. So you can see from here, further that definitely, HIV one is more, is the see in pediatric, it's just sort of important. Now, looking at Gambia statistics on our West African countries, you can see we are far ahead of many things. So we are working very hard, to uh, to defeat this disease. And that's the manifestations. These are some of the manifestations you can find in this kingdom. Thanks. And then, if you look at some of the challenges there, we have what they call mortality before even HIV, from a raw bomb. Sometimes before they go to the clinic, diagnoses are made and all those things. Because of that late presentation, you are unable to put them on ARV, and some of them they are lost to follow up. See, the most group most affected is less than 2 years. And then, so we see the clinical manager after managing them, those who on ART, as you can see, the improvement so it's just to mention that there's integration and then simplification of care, and then that's the deliver what they call point of care services, and then digital, which means electronic registries, so that people are not then capacity just you can see in our country here, we don't have where we have therapies and small to use but for reasons. But like if you are able to and nurses, they can do the job. Thank you. And then these are some of the challenges that we have. But if you look at our health system itself, it's still fragile. That's it. And you have all the concerns that I've already said to staff of country, the development, and sometimes how to make this diagnostic and supply chain management, all those data systems, how do you get this data? We have difficulties in this. Next. And then policies. So develop some policies, and then try to strengthen the system, capacity building, community engagement, and all those things. So now we look at it, build too many hospitals now. I think now we need to find a ways of how to strengthen those hospitals to able to do this work. To be able to do this work. I think that's now where the challenge is. Like, well, how do we get this, diagnostic facilities, treatment facilities, so that the hospitals can function for us very well. Next. And then these are some of the targets of UNAIDS. So I don't know now how are they going to this. So this policies stopping it. Next again. So pediatric HIV infection, I think it's a very important thing. Still, the burden is very, very high because some of them may not even come to the hospital, so we don't know. So it means we need to uh, uh, do more, engage our political leaders and all the other important people, so that try to cope. Next, and these are some of my recommendations that we can um, put together. Care of this. Sure. Exactly. So this is the epidemiology infections in the Gambia. If you look at it in the Gambia, and those are done if you ask sometimes just currently because one of the research about something so see but something also 70% see a child suffering from a respiratory condition. 60% of them will be like from RSV, influenza, influenza virus. And if you look at that one also again, the same statistics, we find out that 70% of them are due to RSV infection in Gambia. So we've contributed a lot to that. So you can see in this slide, there are only I see one of the ICU students, the student, similar November and December, while other studies, earlier studies also said from June, July. So you can see that if you got the RSV vaccine, the new RSV vaccine, give more RSV vaccine, then they transfer the antibodies to the mother. You can say you can cut that infection down. You can bring it down to maybe around 20%. That will also help the country. Next. It's going okay. Next, okay. So you can see these are some of the risk factors from our own study here. Age less than 6 months, and there's other studies that are telling you prematurity, malnutrition, overcrowded housing, and maternal infections are all part of it. You can see different studies from 2000 up to 2024. Yeah, next. These are some of the so during our study here, you can see most of our cases, we only give them supportive management. Some of these other things, very rare, we give them. And I'm very happy to tell you, our data stand out, and then our management was very okay. So these are uh, the department of that art as I told you. Hi. Yeah. Now, now in that sound that I get one of the simple study and other countries now go involved. Most now the government now systems to the country and that is very important here. Said to go to our and this time and our our so this so so also this one also still the transmission is still high. Higher than that. Yeah. So this is about how SCM program. So this is also the so that the one that was actually solving us here is that because of those yeah that from 1997 to 2009 and I went down from school to its highest less than is nutrition also yeah. So everything else the story source of CMC that Yeah. And student assistant. Um, some clinicians have started, using coding again. Yeah, they start. MC something social bodies systems. That yeah. Oh, yes. Yeah. As it you can see, uh, yeah, yeah. Traumatic heart diseases is also another problem, but you can see that one also is solution very well because of the axis. So if you find out that, congenital heart disease at to hospital, at least 8% of our adults are disease. And then if you look at the work moving ahead, some, some 1,000 baht. Uh, yeah, yeah, now we have a so, and, um, and It's like this type of shilling prophylaxis also help a lot. Yeah. And also, so you can see so as usual, how to all the diagnosis treatment and then uh, capacity building and advocacy. So I'm very happy that this year, this channel, in, since, but, and I, sub-Saharan Africa and Gambia. So you can see from here, you can if you can mad adventure, sepsis today they're still diverse and very, very high. Yeah, but in the first 24 to 72 hours, and then those who make it, so they at least like something like 15% will end up being a day. So these are the issues here. So they have still remain a very big challenge. So it's really if you are able to have able to cover, so BR, California, and then have people there, we trying to take care of them. To be said, this work is see the still birth rate in the Gambia here still remain very high, and neonatal mortality rate, infant mortality rate, you can see they still remain very high, and even the under 5 mortality rate also remain very, very high. You can see in 1989 to 1993, infant mortality rate was on the decline. Season. So if you look at from 2000 to 2010, modest improvement. And then in military bits, and then we have only got 2000, you can see the reduction to 35, uh, 1,000. And you can see the military development also still good. So you can see now our own story. So our own to be doing this. But otherwise, no people directly against you. Well, they look at you, maybe a stop something that healthcare provider. That's when actually you are making strides, and people are not seeing this thing. You see, it was at 1989. Now at 2024 now, it is now. So it's not data. It's not from the final pandemic there. So that's why I'm making progress. There's about each people. So can see these are some of the causes of neonatal deaths. So you can say only only the neonatal and health system. Yeah, because sometimes some people die not because of the patient, the mother, or just because of the system weakness. And so the system and socio-economic and also attached to it. These are some of the oh, it's just like their own center. So when I try to take care of this, so we will be able to improve stats. So some stuff we are you can also uh, So, 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 so you can see the things in, child mortality. So you can see, as I said before, it was around 34 life, but now at 34. So, so you can see that. So you can see, uh, so simple search studies in the Ghana here also. You can see it's another very important. Early diagnosis is also important here. So can here uh, nowadays, if you go around some of the country, I want to find out that there are, if you go to Master to find out that they are doing what they call this master. They are using screening. They are screening up patients there with master. And even now, everyone from small to youth hospital do the same thing. And others are using what they call hemotype SC, sickle cell scan, and all those. These are so easily, and it's now around the country. So that's why we have to try to do it now. That's it. So you can see, know, see, they were able to do for us, situation. So it's not 20%. Now, so I can see that something like 57% of them are low quality of life. And if you look at in terms of severity, you find out that 66% of mild severity, only like 30% at like moderate severity. So you can see 80% of them have severe. The type of haplotype that we inherit in this over here, sorry, in Senegal, Gambia, Senegal, is of more severity compared to parts of the country. So, so guys, if you got charge, well, there's no support. And then, we limited access. Start our yes, not difficult. A weak term follow-up or a lack of centralized sequence of the history. That the data that we are given is from our own thing. If you go to what they call the non-communicable disease, we don't find it there. So As system of these are some of the yes. Another thing that we have now in this country is the problem of uh, uh, TB. I think TB is also another issue that in the Gambia here. If you look at it, something like 170 per 100,000. So it's also another challenge. And then one problem that we are also facing is like resistance against some of these so resistance against some of the drugs that we are given. So sometimes you have to go for the second one. Drugs. Also resistance. Especially if you look at in the Gambia here, if you look at it, it's very, very high. Because 400 will have died. 400 life have lost because of antimicrobial resistance, which is and still, even at 2021, it's still a big challenge. Yeah. It's 2021, even now, it's still a big challenge. You can see, and most of them are under 5. Or the people admitted at ICU, but they're severely sick or old age. So, so you can see some of the uh, microorganisms like Staphylococcus, Klebsiella, and others. Most of them are resistant. I remember in 2018, we had an outbreak of Klebsiella, resistant Klebsiella. We were given antibiotic and it's not improving. So we even end up, vacating the NICO, try to, clean it before we can get there. So these are very important. They are still imagine and there are protocols being developed. And then if you look at in terms of cancer, it's another thing that we go. Because if you look at 2024 of Simon, okay, and this thing, you look at the person that they have committed. You can about no, Williams tumor was found to be 27.3%, followed by leukemia and all those things. So these are very important. These are things that you find this thing anywhere. Get starting most of them, they present very late, for 8 months. Yeah, and if you look at the treatment also, refusal. There's some people who just refuse the treatment. They will not like to take the treatment, especially when this mentioned to them that this is cancer. And if all those in the refuse, something like 20 of them. And some of them will even abandon the program at all. They will not even get there again. I don't know. And then some of them, how to get that medication because they are very expensive. Those are some of the challenges that we have. So, and if you look at that, only 20% of these people finish complete the treatment. 20%. 20.5% completed. And if you look at the mortality rate, it's around something like 18%, pass. That's it. See, so you can see the metastasis and all those things, 75%, and then maybe severe drug toxicity and all those, and that even discourage people, discourage patients to refuse treatment. That's it. So what they highlighted was the key delay in presentations, limited drug access, and inadequate supportive care. Yeah, contributed to poor outcome, and urgent intervention is needed. That's what they said. It's not from me. It's the researchers themselves. They can be here. So these are some. So, it's this, cancer unit, pediatric cancer unit at Edward Francis Hospital. So,
So our next speaker is a senior emergency medicine specialist and a healthcare leader from Ghana. He currently serves as the National Maritime Hospital and has advanced secure and critical systems. I tried to look at the work of the people that I am going to introduce today, and I was able to read his thesis, and I was very impressed with the work he has done on emergency medicine policy in Tamala. So, can you see? So,
For your kind words. Question first, my name. This morning I have the pleasure of presenting on triage and stabilization of the polytrauma patient. I'm going to try as much as possible to stick within the confines of the time allocated to me. So I'm going to try to be just a little bit interactive. So be expecting me to ask you some questions as we go along so that, we can pick as much from the presentation as possible. I'm not just going to just rattle things as it were. So our learning objectives today, we're hoping that by the end of this presentation, we'll be able to define what polytrauma is and understand its epidemiology. We will be able to master the principles of the trauma triage systems, be able to do our primary and secondary surveys, be able to execute some life-saving interventions during the initial stabilization. We should be able to understand the importance of team communication and coordination. Sorry. We should also be able to apply damage control principles in polytrauma management and recognize when and how to transfer patients appropriately and implement quality improvement measures in trauma care. So what's the definition of a polytrauma patient? Who is a polytrauma patient? So we're saying that this is a patient who has multiple injuries, as it were. And these, it's not just injuries in one region, but they are injuries in different systems of the body, all right? Or it also may be that you have, in the same system, you have multiple injuries that are adding on and aggravating the issue in the patient in general. So key characteristics are that one, there are multiple injuries, there are two or more significant injuries. You have body regions involved like the neck, the head, the chest, abdomen, pelvis, extremities. Again, key characteristics are that you have the injury severity score of 16 or above, or that there is the presence of a life-threatening injury. Again, a key characteristic of a polytrauma is the concept of the golden hour, that these patients are patients who you need to act very quickly, and that acting very quickly will have an immense consequence on what the outcomes would look like. Again, like I said, some of the characteristics could also be that the injuries might not necessarily be so huge at a glance, but there are multiple injuries that are influencing each other. And so they come off in the long run to give very impactful issues. And again, the other thing about polytrauma is that it normally would require a lot of resources in being able to manage it. Epidemiology. So globally, is the leading cause of death under 45 years, is the fourth leading cause of death overall. and it contributes significantly to disability worldwide. And of course, if it is doing that, then we would expect that from a business perspective or from an economic burden perspective, it's quite huge. What are the mechanisms? We're looking at MVAs, we're looking at falls from height, we're looking at violence and assault, we're looking at sports injuries, we are looking at industrial accidents, and the figures are as pasted. Again, what I want to leave you on this slide is that acting quickly makes a huge impact. And all of the research shows that if we're able to act quickly in the care of these patients, we are able to get good outcomes overall for these patients. So if we are going to manage these patients, we must have, after we know what the definition is and after we know what we need to do, we must establish or have an overview of systems, that would help us to be better able to manage, because I'm saying that if we manage well and quickly, we are able to get the impacts. So my next slide is looking at what the components of a trauma system should look like. So it's starting right from the pre-hospital care and also looking at even quality assurance and research programs that needs to be part of a trauma system. So you're looking at your EMS, from your pre-hospital system, your first responders. In certain countries, we have air medical services, all right? And then when we come to from the hospital, so we're looking at the hospital systems, and we're looking at how the different kinds of trauma hospital systems we have to be better able to take care of our patients. So we have this is well documented. Here in Africa, we actually have, level 1, level 2, level 3, level 4. But if we look at what it should comprise of, I am sure we pretty much have that here. So if you take a level 4, for example, a level 4 hospital system should have at least general surgery available. The general surgery available doesn't mean the general surgeon must necessarily be in-house or present, but they must be on call. And of course, you should also have systems or policies with regards to transfer. In the event of to get them that transfers this patient, and escalates the care to another facility. And 2, have general surgery and subspecialties present that hospital, and the surgeons must be on call. So you can't be on the 2 if you have the surgeon present, on the ground. And it's just for the level, but in addition, try to have a research component to this facility. So teaching hospitals. Exactly. So you have patients, you have a lot of patients coming in, categorizing them basically based on the severity of their injury. But this is also to help to allocate the resources that is important to taking care of these patients. All right. So the trial is a process of prioritizing patients based on the severity and the likelihood of survival. These are the available resources. The concept of triaging started, especially in the world. You have a lot of patients coming in, and you need to quickly decide on who should get treated and who will benefit the most from these resources. So the goal of triage is to save the most lives as possible, to optimize the resources which are available, to minimize preventive death, and to reduce morbidity and mortality ultimately. All right? The triage categories, in this particular slide, I talk about 4 main categories. Where after you triage, you see this is life-threatening and it's salvageable. You delete that patient as red, or that is patient is urgent but stable, or is minor, green, patient is or of course, if they are dead, and they are black. There's no sign of life life in that patient. Now, I know that to trach like the SATS, that's the South African Trach Scale, which introduces an orange parameter in your trach colors. But this is looking at traching the polytrauma patient in sort of a mass casualty scenario. So we are not having the orange categorization in there. That's what you are familiar with. This is just looking at four colors, which is red, 30 patients at the scene, and the way we are charging them is when the responder gets there, we are asking, hello, those who can walk, kindly to the left. And we have like 10 patients walking to the left. These patients become your brain. So we're checking media pulse to see if it is present. If media pulse is present, then they are also charged as a red. Some people use capillary rate of less than 2 seconds. If that is not present, then these patients are also categorized as red. Okay? And then for 5, the stats is looking at mass casualty. We're trying to handle the patients. We are trying to do some interventions. Now, the has a timeline of 6 seconds. So within 1 minute, you should really have 5 steps that are outlined within a minute. That you do a chin lift and a jaw thrust. That is the intervention you are allowed to do within the 60 seconds that you are charging this patient. And after that we would be able to decide on what we can do for the patient on the field. Criteria, this charge algorithm, okay, and there are different patients. These are the things that we must find in the patient. And once you find this patient must be transferred to a trauma center, one trauma center. Algorithm scale. The other category so you've done a physiological, maybe the physiological markers that I just mentioned. You go to the next step to see if maybe they are there. So this is the anatomical criteria. So do they have penetrating injuries to the neck, to the head, to the torso, extremities? Do they have a chest stability? Evidence of a fluid chest or up to a bed proximal fractures, or do they have a crushed, degloved, or mangled injury? Do they have pelvic fractures, paralysis? If these parameters are there in your step 2, this patient must quickly be rushed to a trauma center on the field with this patient. Is it understood? So let's say maybe we didn't find any of this in step 1 and step 2. So we go a step further. And this step is looking at what the mechanism of injury was. So is it a fall from height? So is it like 6 meters and more? For children, we're looking at 10 feet for children. Or is it a high risk crash? Some of the things that you have to look out for is whether there was intrusion. So by intrusion, we're saying that if you took the occupant side, the sides were activated. So the driver did not die, but the person sitting by the driver died. This is a patient. If it's there, this patient must go. And then, of course, if you have vehicle telemetry based on the data, you know, this patient will also to a trauma place. So far, these 2 algorithms of triaging, are we able to do that confidently? Yes. Let me see my hands. Yes. Oh, if I can't see my hands, it means I'm wasting time. So I will just go and sit down. Yes. All comfortable. All right. So let's do our initial assessment. So our initial assessment, I mean, throughout all of our schools, the ABCDE approach has always been run into our head, and it's the same thing. So we represent with protection. We're talking more about circulation, circulation and control, disability, and
exposure. It allows us to systematically it helps us to address life-threatening conditions. So in that assessment, that find a problem, you have picked the problem. Okay, all right. It also helps. So let's look at A. So assessment. In the area assessment, we are looking, we are feeling, we are listening, and we are feeling. So what are you looking for? You are looking for obvious obstruction. Okay, so I come in my A, Lamin. If he's talking back to me, I know that his airway is tainted. But once I'm mentioning his name, I see that he's got some what the sausage we have for this breakfast packing over there. I can see an obvious attraction, so I need to deal with it. We're listening for Friday. We're listening for Horton. As he's talking back to me, so I come and as she's lying there, I come close to her nostril, and I am what may fix it may be a jaw thrust or a chin lift. Okay, whilst we are still maintaining our C-spine, we may need to put in some airways. So we have an oropharyngeal airway or a nasopharyngeal airway that we may need to put in to be able to make the airway fit, or we need to put in an LMA on the board. I hope you are familiar with these adjuncts I am mentioning. You are looking at the chest rise, you come close to the patient, you see that the chest is rising. Chin and feeling are there. See, for things like heart rate, blood pressure, pulse quality, skin color, temperature, capillary flow time, urine output. Okay, and these are the different classifications of shock. Hemorrhagic shock, assessing these patients. So okay, so our third step is to apply direct pressure. So you are seeing the bleeding, your hands are gloved directly on the place where you are seeing the bleeding, you are applying that pressure. Or you put the gauze over there and you apply the pressure directly on the bleeding. That is not working. To gauze very tight pressure dropping to secure hemostasis. If that is not working, then we might need to do a tourniquet where about 2 to 3 to 4. So secondary survey is a systematic head to toe examination to identify all injuries after the life-threatening conditions have been addressed. So we were doing the ABCD initially for all of the things that I've talked about. Our goal is to fix all of these things before we move to the secondary survey. I repeat, secondary survey cannot happen until primary survey is completed. At any point in time, secondary survey does not occur. So secondary survey will start with history, and normally we use sample to help us direct the kind of history that we are taking. So as for the signs and symptoms, allergies, medications, past medical history, labs, secondary survey will do a detailed physical examination. We do our diagnostics and continue with our monitoring something is occurred. So this slide is just looking at the things you out for when you are doing. And times I see my medical officers and house officers sort of like glossing over things. We are examining the things and they are looking at the things that are not finding neck examination, and all of these things. They are there. So an expanding hematoma, active arterial bleeding, stridor or voice changes, and subcutaneous emphysema. These are red flags. Chest, a lot of the things we've talked about before, but it follows the HIPAA algorithm, which is inspection, palpation, percussion, and auscultation. All right, and these are some of the. It's not changed. It's not changed. And these are some of the things that you're on the lookout for. So in your inspection, chest wall symmetry and asymmetry, in your palpation for stability, subcutaneous emphysema,
you're looking, when you are percussing, you're looking for your dullness, your stony dullness, your resonance, your hyperresonance, to make diagnosis. And in your auscultation, you are listening to the quality of the sound, whether they are bilateral, they are not bilateral. You are listening to the abdomen. You are listening to the pitches of the sounds over there and their quality. You are listening to your heart. Can you hear it? Is it muffled? You're listening for all of these things to be able to make some diagnosis about sonography in trauma. And this is a very important tool that to detect that the patient is having some internal pelvis and extremities still the same inspection palpation. But I just want to highlight that assessments for the pelvis, please, and again, I know it's uncomfortable. Put your fingers in them. Also look at the urethra, look for some bleeding going on over there. And the last thing, look for your anesthesia, like your saddle anesthesia. Check around the pelvis, see if there's whatsoever going on. For those who have, so the fact that I talk about 4 views, so the quadrant, which is looking at the that's a Morrison's pouch, or the quadrant, which is looking at the that's the blood glass, and then the subxiphoid, which is giving the cardiac. 2 to 3 minutes, you can find out so much with just those 4 groups. Okay? And this is a very important skill that we patients on stable, blood pressures are tanking, patients' level of consciousness is these patients to be we have aim is to establish right and start aggressively with examples for is how this is done. Because of time, I can't go. And then I also want to just touch on the principle of damage control with extinction. So the principles, like I said, retention, minimizing crystal to give that product if you can access that, and then a rapid surgical intervention to control also prevent hypothermia. Training first pain and ligation and shunts, but after that you're looking at if, for example, so I've outlined one specific injury. I'm good. Okay. All right. But for chest trauma, so tension in the thorax, this interesting experience is missed out in our investment because we are examining the trachea, looking for tracheal deviation, checking your GBP. When is the last time you checked GBP? Okay. Something that but this is something that the moment you pick up, you can totally turn this tension into an by sticking 14 gauge into your second intercostal mid-clavicle, which is good. Like I said, I talked about so that pressure does not build up because oxygen is routed one way. Clean chest normally pain control respiratory support is fine. There may be times when to meet this patient just to go through the life of this patient. Massive pneumothorax, that's when you have about 1,005 so specific treating the I just want to highlight what the patients for laparotomy in these patients are. One, if they are dynamically unstable with a positive past, if they had evidence of peritonitis, there's
situation or so just extreme that's at the background in the context of trauma to theater. Whereas you extremities are related, a few things, but just to draw your attention to our suspicion is in it's to that kids are slightly surface area. So of course they are to get laws and so to balance for them. Remember that very to it's a very, I'm sure, Doc, it's a very to that to height of the patient, what the potential weight of the patient is, and in terms of medications, to quickly tell how much of what is for that patient. So that's this thing. That transfusion happens and also patients are also to be considered and this is so unfair. Is wrong. It's like a and that's the case. Like very significant in like in the look at so I also so if they don't have the reserve, so aggressive treatment of patient can actually act on them in terms of getting from higher risk of which is also a embryonic situation, assessment, and sort of capture so that you don't details or you're communicating with other teams. So it's highly, of course, you might have a shape that is clean, that is this is a tricky one, fat compartments, especially in liver extremity injuries. The patient comes in, was fine, now it's not fine, it's stable, just are tanking, they might have thrown, some fat somewhere, and it's what is causing this. So now there's so much happening. One of the things I want to highlight is your resuscitative endovascular balloon occlusion, where to help secure hemostasis, we can pass a catheter from the femoral all the way up into the aorta and then blow the balloon so that we stop the amount of blood that is going to the extremities. This is where technology has gotten to, and this is where stakeholder engagements should be focused on, so that we can have all of this gamut of things that we can do to help secure and save our patients. If primary survey is not done, we don't do secondary survey. Time is of the essence. Teams are important. Damage control, quality improvement, important. Rapid triage and prioritization, airway control, C-spine stabilization, hemorrhage control, shock management, neurological assessment and protection, and adequate exposure. Remember that regionalization of trauma care, quality metric standardization, injury prevention programs, rehabilitation integration, and long-term tracking are all things that are needed to ensure that we can safeguard the life of our polytrauma patients. Thank you very much.
Thank you very much, Dr. Kwasi, for that presentation. Okay, so our third speaker is going to be a consultant pediatrician, clinician scientist, a medical educator from Nigeria, a fellow of both the West African College of Physicians and the National Postgraduate Medical College of Nigeria. She is also a clinical fellow of the Royal College of Pediatrics and Child Health UK, a Merck Foundation scholar. Passionate about child health advocacy, she continues to advance pediatric care and medical education across Africa. And her topic is going to be pneumonia, critical care challenges in resource-limited setting. Welcome, Dr. Fatima Abubakar Ishaq.
Good morning, distinguished ladies and gentlemen. My name is Fatima Abubakar. I'm a pediatrician from Nigeria, and I will be speaking with you today on severe pediatric pneumonias. I know we've had a lot of lectures today. I won't bore you down with so much of it, but I'll just take you through the critical scenarios and the burden of this condition in their Africa. It is a great honor to be here with you, just to share my insights on my clinical experience and the research made possible by the Merck Foundation through the capacity building program. So just as a preamble, it's good for us to lay this foundation that in every second, there's a child all over the country having challenges with breathing. And over 2/3 of this population are situated in our communities and in a hospital in their countries and continent. So I will take you through this presentation following this outline. By way of introduction, please. Pneumonia is a major killer of under 5 children worldwide, with most of the burden mostly in African countries and South Asia. You now understand why this topic is very paramount in today's discussion. The clinical spectrum can vary from mild respiratory distress to severe sepsis and respiratory failure, with many factors constraining or contributing to this clinical outcome. Most importantly is the resource constraints, limited access to diagnostics, medication, and intensive care facility, which is hence, prevention and early treatment is a prompt action to this disease. And early recognition, effective management can save a lot of lives. So WHO was able to come up with this diagnostic criteria, so we can have a uniform diagnostic criteria that where if Mr. A apply them and Mr. B apply them in different contexts, should be able to come up with this diagnosis that can fit any child with or without any investigation. And they come up with this severe pneumonia in the child aged 2 months to less than 5 years that is having cough, difficulty in breathing with danger signs. So these danger signs are being defined by either the child not being able to drink or breastfeed, persistent vomiting, convulsions or seizures, lethargy or unconsciousness, severe respiratory distress defined by grunting, severe chest indrawing, and hypoxemia of less than 90%. So any child with these features should be tagged as having severe pneumonia, because it's very important for us to identify it early so that we can rescue this child from having the mortality. By way of epidemiology, is the leading cause of the most infectious cause of death in children under 5, and mostly you see them ravaging children less than 2 years, and they represent about 15% of under 5 mortality worldwide. Incidence is about 120 million cases annually, and about 740,000 of under 5 die annually from pneumonia, mostly in low resource settings. Most of these deaths are 50% in sub-Saharan country and 30% in Asia. You now understand why this topic is very important in this gathering. Top burden countries is my dear country, Nigeria, which is why I'm very passionate about this condition. India, Pakistan, Democratic Republic of Congo, and Ethiopia. So this is just a global map to highlight the burden of this disease with incidence. You can see the map there. Those that are colored in yellow and orange. And the first one, the early one, that is the burden in Asian countries. Then when you move to the African country, So this is the Asian countries. You can see the border around the South Asian, and then you can see some part of the Asia is still a little bit not affected compared to Africa, where we have almost 80% or 90% of the map being affected by the disease. And most of it is being seen. You can see those ones in the dark yellow are the ones that the body is much more compared to the ones in the yellow. Of course, all of them contribute to the morbidity and the mortality of the disease. And there's some bit of it here. So this is also a map showing the death mortality per 100,000, which is just similar to what I just showed. Of course, where the incidence was high, is also you can see a reflection of it on the mortality of these children. So by way of clinical presentation, the symptoms actually sometimes can start as just a mild cough or some fever, which can deteriorate, or child presenting with chest injury and inability to feed. Some symptoms like respiratory distress, hypoxia, lethargy, cyanosis, and pyrexia are all things that you can also find in those children. Diagnosis, like I said, is often clinical. Of course, the WHO diagnostic criteria help us to have a unanimous diagnostic criteria for every child. As such, early recognition is survival. It means survival. And making training and recognition is also crucial. So what are the causes or the risk factors that put these children at risk of this disease? Why the under fives? So topmost of is infections. Usually, we all know that extreme of ages are usually at risk of having infection, and the children are not left out in this bracket. So infections, the bacterial pathogens like strep, pneumonia, Haemophilus influenza, viral pathogens are also excluded. Other contributors are the mycobacterium tuberculosis, fungal infection, especially in immunocompromised children. As the first presenter, they talked about those that have the high burdens of HIV infection are also at risk of this pneumonia because they are already immunocompromised. In areas with high HIV or TB prevalence, opportunistic infection like make pneumonia more severe and more difficult to treat. As such, co-infections increase severity and mortality. Other co-founders that makes children more vulnerable are malnutrition, which weakens immunity. And of course, this creates a vicious cycle where the infection predisposes the child to malnutrition. Malnutrition continue to break down the immunity of that child, and it goes like that, like a vicious cycle. So they are brothers and sisters. Lack of immunization. We see battle with this in Africa. We still have a lot of areas where more than 2/3 are having zero immunization status. I say zero, not even some percentage. So this is really something that we should also be looking at, not only the infections. So topmost of it is the pneumococcal infection, HPV, TB, measles. We still have measles outbreak, pertussis, diphtheria. We still have outbreak of that in numbers. And that's how this disease has come to stay with us. But we can do a lot to sideline this story. Environmental factors, the indoor air pollution from our biomass. Most of us still use the unclean gas, the charcoals, the firewoods, the incense. All this contribute to this mortality and morbidity and the worst outcome of this disease. Overcrowding, which spread disease very fast. HIV infection and other community. In fact, when the first presenter was talking about 15% prevalence of that, I was like, are we really living this data? Are we really working on it, or we're stepping backwards? Vulnerable population, the children are there, delayed. So on top of all these factors, we now have other factors or other logistics that are very peculiar in our environment. Delay healthcare access, either due to cultural belief, due to cost, or due to distance, or unavailability of a healthcare. So we're going to look at the diagnostic challenges, even though we say the diagnosis is usually clinical. But often or not, especially in the immunocompromised individual, you know, even in a normal child, you want to ascertain the diagnosis because there are other differentials that can mimic this. And that's how it's good for us to have a chest X-ray, which is often limited in our environment. In fact, the global practice is moving towards ultrasound, chest ultrasound, because of other complication or other adverse effect that comes with the radiology. But of course, as a pulmonologist, I think I've only found it being used once in my center, which is one of the tertiary institutes in Nigeria. then you see we have a lot of work still to do. Microbiological tests and post-oximetry are very important, yet they're still limited in our tertiary institute. Lack of awareness and training of health workers. So we did a survey based on this just to find that in the tertiary institute to know how much the knowledge that the healthcare workers know or how to diagnose pneumonia. We're amazed on the article. More than 2/3 are not aware of the WHO criteria of diagnosis of ARI or pneumonia. This is in a tertiary institute that has been like a referral center to major cities and even some neighboring countries. Then you can now imagine what is happening in the rural setting. And then you now see why the mortality and morbidity keep on rising. So we are not only left down there. Most of our community, even among us health workers, maybe because of the logistics in the hospital, maybe because of the availability of the. So what is the management in the resource? What are the management protocols for this condition in resource limited centers? The WHO, apart from setting criteria for this definition, also came up with management protocol where they made mention of the first line and alternative line. So this is not only peculiar to pediatrics, it's also in adults. I don't know if how many of us are peculiar or have knowledge of this WHO treatment guideline for respiratory tract infection generally and then pneumonia. Anybody? Of course, you are a pediatrician, except you. So you can imagine. You can see the doubting how this area has been neglected, and yet we keep on saying is a major cause of death in the children. In your own assessment, thinking this patient will need the oxygen more than, there may be more than 5 children needing this oxygen. You now have to assess based on, I don't know what criteria, but maybe experience, you just feel that this one saturation is 90, so he can survive. You give it to one that has 80%. So again, that's another thing. Even for those that have oxygen, again, the what is it called? Electricity supply again can be so epileptic that sometimes you put in there and you move to the next patient before you come back, no more oxygen, there's no light, and then you forgot, and who knows? And then patient can die, and then you start looking for other reasons. Whereas these are one of the small issues or little issues that we could have addressed and could have prevented that. Other supportive care are intravenous fluid, for those that are dehydrated, nutritional support, antipyretic, monitoring of complications. But overall, is an unmet needs. You can understand these are children where we say the higher burden is common among them, yet we'll talk about the common medication or treatment guideline, which are antibiotic and oxygen every step. And then as I bring a positive point, there are 3 to 5 points to counteract that. So treatment usually varies widely depending on how lucky the child is. So what are the critical challenges? These critical challenges ranges from all the 3 M's that we usually say, the manpower, the machineries, other supplies. But of course, when we say severe pneumonia, we are not talking about just pneumonia, because the way WHO kind of put criteria or categorize pneumonias are, we have those that we call the acute respiratory tract infection. Then among the acute, we have the upper and the lower respiratory tract infection. The lower, again, they further categorize it into just a simple pneumonia and the severe pneumonia. And we're talking about the severe pneumonia. So these are patients should have been cared for, minimum, a high dependency unit or the intensive care unit. Again, I'll pose this question. How many of us has a pediatric intensive care unit in our facility? Yeah, from which country, please? Ghana. Kudos to you. Which country? Well done. Well done. At least you are from Rwanda, Ghana. Maybe I'll come and have a visit, right? Gambia. Oh, I'll come and I'll come and talk to you after the presentation. So these are patients. So you can understand we only have like 3 countries among all the beautiful countries we've been mentioning here. So the number is still very, if there is a word more than little, it's still minimal for this, given the magnitude or the burden of this disease, where we're talking about every child struggling with breath every second. So lack of pediatric ventilators and monitoring equipment is another major problem. And delayed referrals due to either distance, cost, cultural barriers, poor transportation system is another major issue that we're still struggling. Unsteady power supply, where I said we're still battling with epileptic power supply. Somebody was, that's why, yes, epileptic, because there's a statement, there's a word that I could use to really describe that. Staffing, we see shortage, there's shortage in the either doctors or nurses or the community health workers, and inadequate clinical mentorship. For some of us, we are really lucky. Before I came in contact with the Merck Foundation, I had a beautiful mentorship of supervisor that really was able to put me through, which some of us are liking. So this is another area I think the Merck Foundation has done beautifully well, and I hope will continue to do well on that. Financial constraints were limited. Apart from the inability to get the funding to buy essential equipment, for the medications that are majorly out of pocket, and most of the African residents, or I'll say our community, were majorly maybe civil servants, peasants, farmers or other, and they expect them to pay this out of pocket. This is not sustainable, especially for a condition that is having a high burden. Antibiotic resistance, which has also increased the morbidity and mortality and worsened the outcome. Absence or inconsistency of standardized protocols. Even for some of us that are aware of these protocols, there are some, a good number, that are still resistant to change to follow the WHO criteria because they still believe in their own way of doing things. So this is another factor. Underlying social determinants like the malnutrition, incomplete immunization, poverty, indoor air pollution, all wasn't the outcome. So we can look at it as this is a multi-layered condition, which we have to unlayer all that to achieve whatever we want to, or want to reduce the mortality and morbidity of this condition. So at this point, I just want to give you a clinical experience of a child, which prompted one of my research studies. He was just a representative of every other child that I'm very sure you must have seen. He wasn't that special, but he might even be a better off child than any other, some children you might have come in contact with. This is a child named AM. He's an 18-month baby who resides with his parents at the rural district and hospital in sub-Saharan countries somewhere. His parents are peasant farmers who only cultivate what they just need to eat. They don't even sell part of it, just for them to eat. He's a full-time baby, had incomplete vaccination, only had the oral polio vaccine, which was given to him at home, but he never had the remaining important ones, the HBV, the pneumococcal vaccine. And he's moderately malnourished, which is not surprising because the parents only cultivate maize. I don't know if you know, or maize, which is majorly carbohydrate. So in the morning, he usually take those carbohydrate, afternoon, evening. So he had background moderate malnutrition before the onset of this illness. He lives in a one-room house with an indoor wood fire cooking. So he presented with a 3-day history of fever, cough, rapid breathing, and mother report poor feeding, lethargy, and difficulty in breathing, unable to drink. On arrival, he was found to be in severe respiratory distress with a temperature of 39.2, and the oxygen saturation was 80% in room air. In addition to all this, there was a delayed presentation as the mother had to walk at least 15 kilometers to the nearest health post. And on getting there, as a health worker saw that the child was in respiratory distress, she immediately referred them to the nearest hospital. And on arriving to the referral center, the attending colleague saw this child and thought of the first thing that came to him based on the assessment was severe pneumonia. Of course, he wanted to order for a chest X-ray, and the chest X-ray was down. So the only pulse oximeter that were able to take the oxygen saturation of 80% was kind of the only one in the world. The lab capacity, we couldn't do any microbiological study to check for any organism that must have caused them, because most at times initially when they present, we could think about other causative organisms like viral or bacteria, but it's good for us to know the organism so that we can give the appropriate antibiotic. Oxygen cylinders was present, but supply was erratic. The concentrator available, again, the power outage was there. And we had no PQ, we have no intensive pediatric intensive care units. Limited staff that are trained in advanced airway management. In fact, we don't have for the adults, yes, for children, no. So it has some systemic factors like malnutrition, incomplete immunization, poverty, and indoor air pollution, all in this child. So you had oxygen, which kept on interrupting with the power cuts. We also had to give intravenous ceftriaxone because from the history, we got to know he has had some medication from where he was coming, so we had to go to the alternative regimen. And the parents had to provide for this, which took them about some hours for them to source for this money. In fact, one of the co-doctors had to contribute some financial so that they can go and get this medication. He also has some support, IV fluid and nutritional support, and continue to be on monitoring. And with other challenges being that this is a critical patient that should have had one-to-one monitoring with a nurse, but the nurse and patient ratio was 1:25. You can imagine the kind of monitoring that this child had. But after 13 days, child was stabilized and was discharged with referral for nutritional rehabilitation and counsel of immunization. So emphasis on was discharged, stabilized. So at this point, for every child, your aim is to stabilize them, for them to be out of respiratory distress. It's not to take care of all the morbidities that has come with. You may have to send them home with some of the morbidities and continue to give you a short follow-up appointments, and then continue to counsel and see what comes up. But the critical lessons, as I reflected on this case, was that early diagnosis and referral could have prevented deterioration. But the basic critical care, like reliable oxygen, monitoring equipment, trained staff directly impact on survival, and addressing social determinants. Nutrition, vaccination, poverty, clean cooking gas, socioeconomic sanction, they're essential alongside hospital care management. So system strengthening should be all encompassing. Supply chains, workforce, infrastructure is as important as the clinical intervention. So like I said, this case prompted my curiosity from the bedside to a research that we did just to change the narration. And also we did, we had a baseline assessment just to know the antibiotic use in under 5 in children with pneumonias. And we found a high rate of inappropriate prescribing antibiotics, which has causing the antimicrobial resistance and also the outcome. This was a paper that we published with the British Medical Journal. And this has prompted us to go back to the table and do a fishbone analysis to find out what are the factors that will contributed to this. In a tertiary institution, why are we having inappropriate antibiotic prescription? So after doing that, we found that there was inadequate training, lack of awareness. It was a genuine lack of awareness. Like there was inadequate supervision. Mentorship was a little bit down. And then the case-based discussion and feedback were not that regular. And we did this. The baseline was for 10 months, which was a retrospective study, after which then we now did the interventional for 3 months. We did the training, supervisions, engagement, case-based discussion, and feedback. And also we presented at the departmental level. And this we followed for 3 months, and then did another prospective study, which came up with a beautiful outcome. Not only did it increase the awareness of the doctors on how to prescribe the appropriate antibiotics, it also reduces the hospital stay of children to minimum of 3 days. We can actually, when they are 3 days, they go home, which has reduced the not only the patient morbidity and mortality, even the service delivery, the burden on the health workers, even the parents, some of them have to leave their homes far away, come down here to come and say. So they were happy. It was so relieving to see that we are sending back home children that are healthy with happy parents. So this is what research does. I invite on every one of us, we should look forward, look towards having researches that doesn't only look at prevalences, but also interventionally. This is a research that we didn't raise. I think the only thing that we spent was the money to print the papers for the pro forma. But the rest of it was something that was, we collaborated. The teaching was among us, presentation, the mentorship. And this is a scalable, feasible, and yet it has changed lives. Not only the lives of these children, but the lives of doctors. They are now confident to now see these children and give them the appropriate management. So this was paper, I think we just submitted it in the ICAS of Childhood and Pediatrics. We are still awaiting, it's still in the production. While the second paper, the BMC Pediatrics, is another one that we will look at the risk factors of pneumonia and under fives. And it wasn't different from all what is there. The highlighted malnutrition, poor vaccination, poverty, and indoor smoke was still very prevalent. And they were predictors of pneumonia in under fives. So what are the strategies and solutions? Solutions, sometimes when we talk about solutions, we start thinking of high diluting stuffs. Fortunate enough, this disease is a preventable one from all ramifications that you want to look at. The solutions don't always require a high index intervention like pneumonia. And pneumonia deaths can be drastically reduced, just like what we experienced in my center. Capacity building, train and empower health workers and retain them, which is a beautiful work which the Merck Foundation is doing as a real game changer, especially in low-income countries. Community case management, which recognize and treat pneumonia using the IMCI protocol, strengthening of the health system, infrastructures and referral system and management protocols, enhancing the diagnostic capacity, especially essential diagnosis tools and training, promote vaccinations, improve community awareness and engagement, and target hard-to-reach population, refugees, nomadic, and conflict-affected regions. To promote rational antibiotic use and stewardship, like the success we had in my facility, and the integration of the National Pneumonia Action Plans aligned with the WHO Integrated Global Plan for Pneumonia and Diarrhea. Research focus and pediatric peculiarity to enhance outcome management and global collaboration to ensure world-based practice. We can actually put Africa in the global context. It's just the commitment that we just had to do. So what are the future directions? In short, the future is to ensure no child dies from a preventable and treatable disease like pneumonia. And all hands have to be in deck. Policy making, research, interventional studies, low-cost diagnostic tools, simplify oxygen delivery, partnership. This cannot be overemphasized. Equity in focus. It shouldn't be only the child that lives in the urban center. That child that lives in the rural area are future minds of tomorrow. He deserves to live. So when we begin to look at it that way, I think we have an equitable place where we see every child deserves to be treated equally. Telemedicine. This is another area that I look forward to, and I hope I will be able to pull it through in my community so that for those of us that are in the urban center, we can actually interact with those community health workers in the community. They are agile, they are ready to give, to be committed, just need the mentorship. So if we can extend this, we continue to mentor them virtually while they discuss with us with cases and cases that they cannot refer, they can talk to us on how to go about it. This will reduce the burden of this disease. Importantly, family-centered care. This is very important. The social determinant factors are very important, just as the infectious agents. Because if the family are not incorporated into this program, I don't think we will move ahead of this. So they should be incorporated. I think this is another aspect that in Africa we are still lagging behind. We see the child as a child himself. We don't see him holistically as a family. So what are the take-home message today? This calls for an urgency. Addressing the challenges of severe pediatric pneumonia in resource-limited setting is critical to reducing child mortality. Resource limitations, delayed diagnosis, inadequate treatment are all the challenges we are facing, but awareness, training, affordable oxygen, and vaccination can save life. Partnerships and innovation are essential for lasting solutions. And I want us to leave this place with this, that we can change the story, but we have to be committed, which will require multifaceted and sustained collaboration. This is my references, but this presentation will not be complete without giving my sincere gratitude to the foundation for empowering me through the postgraduate diploma in respiratory medicine. This training has enabled me not only to strengthen my clinical mentorship, but also conduct researches, publish international, implement intervention that improve child health outcomes in Nigeria. Also to my dear hospital, Usman Danfodio University Teaching Hospital, who the chief medical director is also an alumni of this foundation. He's a mentor. I think he was here. Maybe he stepped out. He's one of those that really encourage us to do, and I'm grateful for that.
Thank you for the presentation. Thank you very much. So our first speaker is going to be joining us online. His name is Prof. Ganesh Bath. He's a professor and head of the Department of Gastroenterology at Kasturba Medical College at Manipal Academy of Higher Education in Manipal, India. He holds an MBBS, an MD in medicine, and a DM in gastroenterology from premier medical institutions in India. He has over 2 decades of experience in gastroenterology and more than 60 publications in national and international journals. So his topic of discussion today is approach to gastrointestinal bleeding in the emergency unit. So over to Prof. Ganesh.
Hi, I'm Dr. Ganesh Bhatt, Professor and Head, Department of Gastroenterology at Kasturba Medical College at Manipal Academy of Higher Education, Manipal, India. In next 30 to 40 minutes, I will be discussing about the approach to gastrointestinal bleeding in the emergency unit, how to manage this patient at emergency unit, and how to prepare the patient for next level of treatment, including endoscopy approaches, and post-endoscopy management. As we know, gastrointestinal bleeding is one of the most common cause of emergency visit among the gastroenterology patients. Patient anyway bleeding from esophagus to ligament of teeth is called upper GI bleed. Any patient who is bleeding from ligament of teeth to anal canal is called lower GI bleed. But with the advent of endoscopy, the area approachable by upper GI endoscopy, that is up to D2, D3, is called upper GI bleed. Area reachable through the colonoscopy, that is up to the IC wall or terminal few centimeter of terminal ileum, is called lower GI bleed. In between area is called mid bowel bleed, that is from ligament of teeth to IC wall. Traditionally, around 2/3 of the bleeding is from upper GI bleed. Maybe around 20-25% are lower GI bleed. Less than 5% bleed is from the mid bowel. So what is the presentation with the patient who is having GI bleed? If the patient has upper GI bleed, they usually present with hematemesis or melena. Melena means black tarry stool. So to have a melena in a patient with GI bleed, at least 60 ml of blood should be there in the gut. If the patient presents with the melena, it may not indicate the active bleeding because melena may persist for 3 days after bleeding has stopped also. So usually the hematemesis or a black tarry stool is the presentation, whereas a lower GI bleed usually is a fresh blood or a maroon colored blood is the presentation. A upper GA bleed can also have a press bleeding BR if the bleeding is very rapid or a brisk. What are the major causes of GA bleed? For upper GA bleed is either ulcer or a varices or a mucosal bleed like a angiodysplasia or a vascular ectasia. Whereas for a lower GA bleed, either it's an inflammatory bowel disease like ulcerative colitis or a Crohn's disease, or a tumor bleed lead to malignant growth or a polyp. Rarely it may be due to diverticular bleed. So what are the etiology and prevalence of GA bleed? So among that, these I'm presenting about the upper GA bleed. In Western population, Europe and America, the commonest cause of upper GA bleed is ulcer bleed. Almost half of the GA bleed is peptic ulcer bleed, whereas a varicose bleed constitutes around 10%. Whereas in Indian subcontinents or in Asian studies, varices are the main cause of upper GA bleed, almost 50%, whereas ulcer bleed constitutes around 15 to 20%. So etiology for upper GA bleed, so the clue is if the patient presents with if the patient has history of NSAID, if the patient has upper abdomen pain, if the patient has a dyspeptic symptom like acidity, burning, pain, or reflex symptoms, that indicates a clue that is a ulcer bleed. Whereas the patient has history of jaundice, if the patient has splenomegaly, if the patient has ascites, then it's likely varicose bleed. So endoscopy remains the gold standard for the diagnosis of GA bleed, either variceal or non-variceal. Not only it identify the lesion, localizes it, and also has a potential therapeutic treatment. What are the fundamental principles of the management of upper GA bleed? So why we have to determine the source of bleeding, stop bleeding either pharmacological or endoscopic modality of treatment, treat the underlying etiology, whether a varices or if it's a tumor bleed or polyp, and do certain treatment so that bleeding doesn't recur. But before doing the source, preventing the source bleeding, we had to hemodynamically assess the patient, stabilize the patient so that patient is fit for next level of treatment, either endoscopy or radiologically or surgically. So foremost important thing when a patient comes with a bleed, upper GA or lower GA, you have to resuscitate the patient in the ER. So followed by pre-endoscopic standard treatment, which I will be discussing later. Followed by once the patient is stabilized and pre-endoscopic treatment has been done, so patient needs to undergo endoscopy. So depending on the endoscopy finding, whether patient needs a endotherapy or a surgical treatment, will further characterize and list for that type of treatment. So after endoscopic therapy, so we have to do certain medication or preventive treatment so that it doesn't recur again. So initial assessment is we have to assess the hemodynamic status. If the patient is either already has a altered hemodynamic or hemodynamic compromise, insert two large bore cannula and resuscitate with the patient so that pulse pressure and pulse rate will stabilizes so that patient can be taken up for endoscopy. So early intensive resuscitation with fluid, either colloid or crystalloids, has shown to be decrease the mortality. So what fluid you have to give? So there is no randomized controlled trial regarding the type of fluid, whether it's a crystalloid, whether it's a colloid, with adequate resuscitation has shown to alter the mortality, but it is not the type of fluid which will change the mortality. So crystalloids like balanced crystalloid like ringer lactate will be a preferred IV fluid over the 0.9% saline because ringer lactate not only helps in preventing the acute kidney injury in a patient with the bleed with the hemodynamic compromise, also ultimately it lowers the risk of mortality. What is the amount of fluid here to give? If you are using crystallite like ringer lactate, you have to give at least 3 times the amount of blood loss. If you are using the colloid or hemaxil or albumin or a blood, you have to equal amount of fluid you have to transfuse. What is the guide to volume loss? How much fluid I have to give to resuscitate or hemodynamic stability to achieve? If the patient has a normal BP, normal heart rate, it indicates that most probable loss of volume loss is less than 15%. If the patient has tachycardia, if the patient has orthostatic hypotension, it indicates maybe around 15 to 30% loss. Whereas if the patient has already have hypotension, that means at least 30 to 40% of loss is there, volume loss is there. You have to adequately resuscitate, including a blood transfusion. If the patient has refractory shock in spite of adequate fluid resuscitation, it indicates that more than 40% volume loss is there. So what about blood transfusion? We have talked about fluid resuscitation. So how much volume you have to transfuse. But now I'll tell you what is the amount of blood you have to transfuse. The current strategy is to have a restrictive blood transfusion. So over the years, we are transfusing over transfusion, which has led to a bad outcome. So now current approach is restrictive blood transfusion to make the patient hemodynamically stable. If the patient is hemodynamically stable, you should target a hemoglobin around 7 gram if the patient doesn't have any comorbidity. If the patient has a comorbidity, especially a cardiac condition, or a patient is likely to undergo any surgical intervention, so you should target a hemoglobin of 8 gram per minute. But if the patient is in hypotension, not responsive to fluid, patient has a metabolic acidosis, especially a lactic acidosis, then it indicates tissue hyperperfusion, so you have to transfuse adequately. There you should not target the hemoglobin level. So initial hemoglobin level, especially within 24 hours, may be erroneous because hemodilution has not taken place. So even though patient has a significant blood loss, hemoglobin may be fallaciously normal. So after assessing the volume loss, after adequately fluid resuscitation, you had to and adequate blood transfusion to keep the hemoglobin. You had to assess the risk. You had to segregate the patient whether patient can be sent home or patient has to be admitted and whether patient needs any emergency endoscopy. To categorize these patients, we have different scoring system. The commonly used scoring systems are one is called Glasgow Blackboard score, that is called GBS. Second is AIM-65 score, which includes altered mental status, systemic blood pressure, age of the patient. Other two are Rockwell score and ABC scores. Among these, Glasgow Blackboard score is commonly used because this helps in deciding whether the patient needs to be admitted or patient can be sent home. What are the component of Glasgow score? It has two examination history finding, like a history of melena and associated comorbidity, either cardiac or hepatic. And it has two physical finding. One is the pulse rate. If the patient has tachycardia more than 100% or patient has a hypotension. Two blood parameters, that is hemoglobin in male and female, and a blood urea level. If the score is less than or equal to 1, it is low risk. Patient can be managed in OPD patient, easily discharged from the ER and asking the patient to follow up in an outpatient basis. Whereas if the patient of GBS more than 7 indicates that high risk of bleeding, not only this patient needs to be admitted and also they should undergo an emergency endoscopy within 24 hours. So the Glasgow Blackboard score is helpful in identifying the categorizing patient, triaging patient to inpatient or patient can be managed on OPD basis. But this GBS is not good to identify the risk of rebleeding or death. Other score which is available or which is not routinely used is AIM score. which includes albumin, I for INR, M for mental status, S for systolic blood pressure. Along with that, 65, that is more than 65. So maximum age more than 65. Maximum score in this you can get is 5. A patient with more than 3 has a high risk of mortality. Patient has to be admitted. Patient has to undergo early endoscopy. But this score is not good in triaging the patient. A patient with a low aim score doesn't mean that you can discharge early. So this score is helpful in identifying the patient who are high risk of mortality and rebleeding, but not good in triaging the patient to OPD or inpatient. One most commonly used recent score is a ABC score. A for age, B for blood test, C for comorbidity. Age, any patient who is more than 60 has a scoring. A patient with a urea, albumin, creatine level will have a scoring. And a patient who has a comorbidity, including liver, cardiac, and altered mental status, will have a scoring. Any patient with a less than 3 score will have a 1% mortality, and any person who has a score between 4 to 7 has a medium risk or 7% rebleeding, and a patient who has more than 8 scoring point will have at least 25% of risk of rebleeding and mortality. So this score is good in predicting the mortality. Again, this score is not good in triaging the patient to inpatient or outpatient. So it's poor in whether the patient is also this score is not good in predicting whether the patient needs endoscopy or not. Next, update about the use of nasogastric tube or NG tube. Traditionally, a decade before, every patient with upper GI bleed used to have a nasogastric tube to identify the source of bleed, and we used to do a saline or a cold saline wash, all those things to prevent the rebleeding. That approach has been changed. Nasogastric tube is not mandatory. It may help to identify the or confirm the bleeding. If the patient comes with a melena, you put a nasogastric tube, if the gastric tube aspiration shows altered bleed, it confirms that is a upper GI bleed, or it confirms that there is a active bleeding. But its use is not contradictory whether it's ulcer bleed or a pericial bleed. You can usually put the nasogastric tube. But most of the guideline nowadays says putting a nasogastric tube is not essential. It may be optional depending on the patient to patient. But if you put a nasogastric, it may help in identifying the bleeding, confirming the active bleeding. Also, it helps if you do a lavage and aspirate the content in the stomach. It helps in endoscopic visualization of the lesion or a source of bleeding. So other than nasogastric tube, the most commonly used is a prokinetic agent like erythromycin, which will help in emptying the blood in the stomach, so improve the visibility during endoscopy. What are the laboratory tests you have to do before taking up for endoscopy? As we told, the hemoglobin or a complete blood count is mandatory. So depending on the hemoglobin level, you have to transfuse the blood, as I told previously, right? Patient has to undergo a liver function test to confirm whether patient has an underlying cirrhosis, prothrombin time with INR, and a renal blood function test whether patient has a renal failure. So patient who has a acute bleed usually have a low HB, but their MCV level will be normal. If the patient has anemia with low MCV, it indicates that patient has a chronic blood loss. ECG and trop T should be done in patient with risk of silent MLE, especially a patient with comorbidity, especially a patient with elderly, maybe more than 60 or 65 years. So what about the management of pre-endoscopy management of antithrombotic agent or either antiplatelet or anticoagulants? If the patient timing of endoscopy is not decided whether the patient is on antithrombotic or antiplatelet, you can go ahead with the endoscopy even if the patient is on antithrombotic or antiplatelet. So timing is decided by the amount of bleeding, not whether the patient is on antiplatelet or anticoagulant. Routinely, we don't recommend to use the platelet transfusion in the patient who is on antiplatelet or anticoagulation. If the patient is on anticoagulant, especially in a patient who has a newer disease directly acting oral anticoagulant, so you may have to give a FFP or presfusion if there is no antidote. If the patient has taken a newer this DOSCs within 2 to 4 hours, you can do a charcoal lavage to prevent its absorption. So there are antidote available for dabigatran and direct the additionate. Whereas vitamin K antagonist like warfarin, you can give either vitamin K injections to prevent the to rapidly normalize the NR. So what about the stoppage of antiplatelet? If the patient is on most aspirin monotherapy for primary prophylaxis, easily you can stop it and restart only when the adequate control of the bleeding and risk of bleeding is minimal. Whereas a patient who is on aspirin monotherapy for secondary prophylaxis, you can easily continue. You don't have to stop the aspirin. So if the patient is on dual antiplatelet, that's aspirin plus clopidogrel for the secondary prophylaxis, then switch over to monotherapy with aspirin and stop the clopidogrel. Restart if the patient is required, especially if the patient has undergone a cardiac stenting within 6 months, may have to restart on dual antiplatelet. Preferably start the clopidogrel after 5 days of endoscopy treatment or adequate GI bleed control. If the patient is on a DOAC, that's newer anticoagulant, so we have to stop immediately and restart depending on the indication of the patient. Again, vitamin K antagonist like warfarin has to be stopped during endoscopy. If the risk of thromboembolism is very high, we can tie the crisis with a low molecular weight heparin and restart the vitamin K antagonist once the bleeding is controlled, depending on the indication for restarting. So, whether these all patient needs to be intubated before endoscopy? No, it's not routine prophylactic intubation is not recommended in a patient who has a moderate bleeding and fully conscious, especially a patient with ulcer bleed. But intubation may be required if the patient is in ultrasensorial like hepatic encephalopathy, if the patient is massive ongoing bleeding, or the patient is agitated, patient is in a withdrawal status, or a patient is mental status is not good, or a patient who is very younger patient, especially in children where cooperation is very difficult. These patients better you intubate and take up for endoscopy. What are the initial management? What are the initial pharmacological management before taking up the patient for endoscopy? Once you resuscitated with the blood, once you resuscitated with the fluid, once you decided to segregate the patient into categories, whether VPD or inpatient management is required. Once you decided on the antiplatelet and anticoagulant, then is pharmacological treatment before taking up for endoscopy. If your suspicion is varicose bleed, vasoactive drugs like terlipressin, somatostatin, or octreotide has to be started. If the patient suspicious of having ulcer bleed, proton pump inhibitor has to be started. What does a proton pump inhibitor does in a ulcer bleed? It not only reduces the risk of rebleeding, reduces the high risk bleeding to low risk bleeding, and also helps in endoscopic visualization. Even though it doesn't have any direct effect on the mortality or a rebleeding or a need for surgery. According to a different guideline, so PPI is not recommended according to the British Society of Gastroenterology. So ACG could not come to a conclusion on the PPI using non-urethral bleed, whereas ESG says you should start PPI infusion before taking up for endoscopy. It not only helps in visualization during the endoscopy, also it helps in downstaging the stigmata of bleed, which I will be discussing in later slides, so that rebleeding risk is low. So what are the initial management we discussed? So not only the other pharmacological agent which is routinely used is tranexamic acid, so which is not recommended nowadays because there is no evidence that it will helps in preventing or stopping the bleeding. Or that it may cause more side effect, especially risk of thromboembolism with this usage of this drug is high, so it should be avoided. Use of vasoactive drugs like terlipressin in a non-variceal bleeding also not helpful. It has shown that it is not going to help in preventing or it adds to the cost of treatment. Timing of endoscopy. Initially, it is emergency endoscopy as early as possible. Now, what we learned is no role for emergency endoscopy, that is within 6 hours. If you do endoscopy within 6 hours, risk of mortality goes up. That mainly because you did the emergency without adequately resuscitating or stabilizing the patient. So risk mainly they die of cardiac or extra GA causes of they will die of extra GA causes of bleeding. Whereas in a variceal bleed, the current recommendation is do early endoscopy, that is within 12 hours. If the patient is suspected to have a non-variceal bleed, ideally endoscopy is done within 24 hours. So delayed endoscopy in a patient who has a low risk, who has been sent home and asked to follow up on OPD basis. ACG and both ECG and ESG is recommend that early endoscopy is preferable rather than emergency endoscopy. So emergency ward, what are all we did? One, we localized bleeding, whether it's upper GA, lower GA, depend based on the history. We have resuscitated the patient with fluid and blood, depending on the volume loss and depending on the hemoglobin level. We have triaged the patient into high risk, low risk, depending on the different scoring system. We have started some pharmacological treatments to assist the reducing the risk of bleeding. And we have prepared the patient with adequate blood transfusion and other supportive treatment. And also we have discussed about the timing of the endoscopy. So next level, what is the difference other than before going to the endoscopy treatment? What are the basic difference between the two types of upper GI bleed? What is varicose? Other one is non-varicose. As I told, the varicose bleed is usually venous blood loss, whereas non-varicose mainly the ulcer bleed is due to arterial loss. So mortality in varicose bleed is high. Mainly, it's not directly because of the bleeding. It's mainly because of underlying liver condition. Whereas mortality in non-variceal bleeding is less, maybe around 5 to 10%, and the mortality entirely mainly depends on the amount of blood and also associated comorbidity. So proton pump inhibitor usage is recommended in non-variceal bleed, not routinely recommended if you are suspecting a variceal bleed. Vasoactive drugs like terlipressin is indicated if you are suspecting a variceal bleed, whereas it is not recommended if you are suspecting a non-variceal bleed. Prokinetic useful in both variceal and non-variceal, especially it helps in better visualization during endoscopy. Antibiotic prophylaxis is recommended in variceal bleed, which will help in preventing the translocation of bacteria. But antibiotic prophylaxis is not recommended if you are suspecting a non-variceal bleed. Platelet transfusion, routine transfusion of platelet is not recommended. If the patient has a deranged INR in variceal bleed, it is there because of underlying liver dysfunction. You don't have to give any vitamin K or a presbyopia plasma. But if a non-variceal bleed in the patient who has an vitamin K antagonist or with the delayed uh, prolonged INR, you may have to give a vitamin K or FFP. Thiazide acid, no role in both variceal and non-variceal bleed. What has changed over the last 1 or 2 decades? So NG tube or a rice tube is not mandatory in each and every patient. Aggressive blood transfusion has been changed to a restricted strategy to have a targeted hemoglobin of 7 or 8 depending on the comorbidity. Emergency endoscopy has been delayed to within 24 hours, no urgent endoscopy. Stopping up antiplatelet, aspirin can be safely continued, you don't have to stop. High dose of PPI is recommended for non-varicose bleed, no for varicose bleed. So how to, once you stabilize, once you started a pharmacological patient, once you feel that patient is admitted and he is fit for endoscopy, so next thing is you have to take in a patient who is likely varicose bleed, preferably do endoscopy within 12 hours. What are the treatment option in varicose bleed? If it is a esophageal varices, we can do a banding, esophageal variceal banding. If the patient is bleeding from the gastric varices, we can do a glue injection or a endoscopic ultrasound guided coiling of the gastric varices. If the patient has a varicose bleed which is not controlled by initial attempt with the endoscopic variceal ligation or a glue injection, we can think of continuing the pharmacological treatment if it is partially controlled. If the patient is hemodynamically situated, continue the pharmacological treatment with endoscopy treatment. If the patient is bleeding massively, not controlled with the pharmacologically, next alternative treatment best available is a TIPS, what is called a transjugular intrahepatic portal systemic shunt. If the patient is not fit for TIPS because of the poor liver function, you can think of mechanical tamponade, either using a balloon tamponade, which is called as Sangstein Blackmore tube, or use a self-expandable metal stent temporarily, which can be removed within 1 to 2 weeks. Acute variceal bleed management current is start the vasoactive drugs, so do use the antibiotic prophylaxis. PPI is not required. EVL is the preferred method of endoscopy treatment in esophageal varices, preferably within 12 hours of presentation to the hospital. Use lactulose to prevent the hepatic encephalopathy because bleeding precipitates encephalopathy. FFP is not required. Fresh frozen plasma is not routinely required. Platelet transmission also not routinely recommended. In a patient who is not whose bleeding is not controlled with the endoscopic attempt, tips or a mechanical tamponade with balloon or stent can be attempted. Whereas in the patient with gastric variceal bleed, glue injection or endoscopically or EUS endoscopic ultrasound guided coiling can be attempted. But in a patient who fails this or a patient with a large stent, we can do some radiological techniques called BRTO, balloon retrograde transluminal occlusion of the stent. Whereas non-varicose bleed, we have discussed about the varicose bleed management. Now we are discussing about the non-varicose bleed. Non-varicose most common cause of bleed is ulcer bleed. Depending on the ulcer appearance, we categorize into forest classification. This endoscopic visualization will dictate whether the patient is likely to rebleed and what is the type preferred endoscopic treatment we have to offer. So, as I told, forest 1A is active spurting of blood, what I showed in the previous slide. 2B is oozing, 2A is a non-bleeding visible vessel, 2B is adherent clot, 2C is flat pigmented spot, wherein forest 3 or forest C is called clean based ulcer. Risk of rebleeding and choice of endoscopy treatment depends on these classification. 1A, 1B and 2A has a high risk of rebleeding, as high as 40 to 55%. These patient needs to be undergone high dose of PPI plus endoscopy treatment. Now, which endoscopy treatment I will be discussing in the next slide. Whereas 2B and 2C has a moderate risk of bleeding, maybe around 10 to 20%. These people also has to be undergo a high dose PPI plus minus endoscopy treatment. Whereas forest 3 or a forest C is a clean base ulcer has a very low risk of bleeding. Usually endoscopic treatment is not advised. What are the different type of endoscopic hemostatic treatment available? Traditionally, we used to use the bipolar coagulation or a monopolar coagulation or a heater probe or organ plasma coagulation. Preferred now treatment is an injection sclerosant or injection of adrenaline followed by mechanical devices like hemoclip application either through the scope or the scoop clip like a ovascoscope. In a patient who is not controlled with these patients, there is a hemospray which can also be useful in selected patients. So if the patient has active bleeding, you can do an injection either with the diluted adrenaline or a sclerosant. You can do a APC or you can use a mechanical devices like hemoclip. Current recommendation is if the patient has a 1A, 1B or 2A, two modality of treatment, either injection or a monopolar or bipolar coagulation plus a mechanical device like a clip. Dual mode of treatment is preferred or advised. If the patient has recurrent bleeding in a non-varicose bleed, that is ulcer bleeding. So on an average, around 15% of the patient will have a failure to control the bleeding in initial attempt. Around 25% of the patient may rebleed after adequate control in the initial attempt. So both the ESG has that rebleeding as following initial successful endoscopic treatment. It usually presents either hematemesis melena after once the bleeding controls, either as a hematemesis melena or a drop in HB more than 2 gram. What are the endoscopic predictor of bleeding? Is mainly the active bleeding, that is a forest classification, and also type of treatment you offer. What you do if the patient has recurrent bleeding? All guidelines says you should give high dose of PPI in a patient who has a high risk of rebleeding. So either bolus or a intermittent infusion or a infusion. Both the guideline ASG and ESG says you have to repeat the endoscopy if they rebleeds. Success with the endoscopic repeat attempt is as high as 2/3 of the patients, so that second relook endoscopy has to be done if the patient has rebleeds. If the patient failed to control even after the second attempt in endoscopic treatment, so either you can think of transarterial embolization through the radiologist or a surgery. So in a patient who has a recurrent bleeding, repeat endoscopy may control the bleeding as high as 70 to 75%. Dual mode of treatment plus over the scope modality like TTC clip may be preferable, plus minus topical hemospray is a preferred treatment. And routinely relook endoscopy is not required. If the patient has ulcer bleed, H. pylori biopsy has to be taken. And once the patient has adequate control of bleeding, so maybe H. pylori testing and treatment is mandatory to prevent the recurrent of ulcer in these patients. So what we learned from the non-varicose management, bleeding management, there is no role for urgent endoscopy. Endoscopy preferably done within 24 hours. Forest classification decides the risk of bleeding and type of treatment, endoscopy treatment you have to do. Two modalities, mechanical plus heater probe, mechanical plus injection therapy is preferable. High dose of PPI is recommended in a patient who has high risk of rebleeding. Relook endoscopy if the bleeding is adequately controlled is not required. If the patient rebleeds, repeat endotherapy should be attempted. If the second endotherapy fails or a refractory repeated bleeding occurs, transcatheter embolization or surgery is the preferable. When to restart the antiplatelet? If the patient has dual antiplatelet, cardiac indication is high, that is, the patient has undergone a stenting within 6 months. Once the patient adequate bleeding has controlled, that's within 5 days, you can start the antiplatelet. If the patient is on monotherapy like aspirin, you can start immediately with the PPI. If the patient is on anticoagulant like warfarin or a newer DOAC medicine, preferably start them after 3 days once the adequate bleeding has been controlled. If the risk of thromboembolism is very high, we can bridge this gap, 72 hours gap, with low molecular weight heparin. Thank you.
Moving forward, we're going to have a presentation from another professor, and he is no other than the Krishna Vishwa Dean University. He is distinguished academic, holding 10 copyrights and actively contributing to research and various committees. Dr. Patil has been actively involved in teaching and training undergraduate and postgraduate students, and also serves as a PhD guide. His topic will be covering comprehensive approaches to autoimmune disease management, such as rheumatoid arthritis, systemic lupus erythematosus, and antiphospholipid syndrome. Over to you, Dr. Patil.
Good morning, all the participants, delegates, and faculty members attending this session. Today's objective for this session is comparative approach to autoimmune disease management, mainly rheumatoid arthritis, systemic lupus erythematosus, and antiphospholipid antibody syndrome. Now we will have a overview of all the autoimmune diseases which are discussed in this session. So etiology and immunopathogenesis as autoimmune disease mainly consist of that basic understanding of autoimmune disease result from failure of immune tolerance, the process by which the immune system recognizes and accepts self tissue. The multiple genetics and environmental factors contribute to the development of autoimmune disease. Autoimmune diseases are relatively more common in women than men. Genetic variation in the HLA, that human leukocyte antigen, environmental factor associated with autoimmunity, and in general, genetically predisposed individuals are prone for acquiring autoimmune disease, which can be or probably precipitated by certain environmental risk factor like antigenic molecular mimicry or smoking, etc. Rheumatoid arthritis and systemic lupus erythematosus are the important causes of significant disability and morbidity among the systemic rheumatological disease condition. Phospholipid syndrome is associated with mainly venous arterial microvascular thrombosis or pregnancy related complication like recurrent spontaneous abortion or unprovoked DVT and pulmonary embolism. To understand basic general concept of autoimmunity in rheumatoid arthritis and SLE or antiphospholipid syndrome is that generally when host cell damage occur, there is one process called as apoptosis. It's a cell program death of the cell which further progress to development of or presentation of this damaged cell by dendritic or antigen presenting cell, which are mainly macrophages and dendritic cell which are present in our body, which represent the major histocompatibility complex, that is type 2, which further presenting this antigen and activating the T cell, which further activate the B cell lymphocyte, which again develop into plasma cell. This plasma cell again progress to form a series of cascade which start interleukin, tumor necrosis factor alpha, which again form the multiple immune complexes, and these immunocomplexes get deposited into the tissue, and this immunocomplex deposition ultimately lead to organ tissue damage or their dysfunction. Autoimmune diseases which we are discussing in this session, these are mainly systemic lupus erythematosus, rheumatoid arthritis, and antiphospholipid syndrome. Again, antiphospholipid syndrome are again divided into two types. One is antiphospholipid syndrome, which is primary, which present in isolation, or it may be associated some other autoimmune disease, just like a systemic lupus erythematosus, which is called as a secondary antiphospholipid syndrome. The genetic, HLA and environmental factor, female gender and smoking, these are the important risk factor in genetically predisposed individual at large. Now specifically we will discuss mainly the rheumatoid arthritis, which is one of the frequent or most common rheumatological disorder in common practice. In rheumatoid arthritis, self-reactivity, that is autoimmunity, play a crucial role in pathogenesis of, which is attributed to the dysfunction in the adaptive and innate immune system, as well as the alteration in the stromal cell. The multifaceted nature of rheumatoid arthritis pathogenesis involve immune dysregulation, genetic predisposition, environmental trigger, and complex interplay of various cell and cytokines. We will now concentrate mainly on the immunopathogenesis on rheumatoid arthritis. In clinical practice, in preclinical stages, the rheumatoid arthritis, both macrophage and granulocyte, can secrete peptidyl arginine deaminase, which is called as PAD, which is one of the calcium dependent enzyme which catalyzes post translation changes known as a citrullination, which convert the positively charged arginine into polar and neutral citrulline, which is called as a ACPA, is caused by an important aberrant immune response to variety of citrullinated protein, including type 2 collagen, histone, fibrin, ivermectin, numerous fibronectin, enolase, and Epstein-Barr nuclear antigen. Numerous citrullination neoantigen would trigger the major histocompatibility complex type 2 dependent T cell activation, which in turn encourages B lymphocyte to produce ACPA antibody against variety of native citrullinated protein. The phase is additionally known as loss of immune tolerance. If this stage continue to progress, the disease will progress to cartilage and bone tissue damage, joint damage, or they may get destroyed. Rheumatoid arthritis associated with anti-citrullinated protein antibodies and rheumatoid factor, which is IgM against IgG Fc fragment. ACPA, that is anti-citrullinated protein antibody, and anti-CCP, that is anti-cyclic citrullinated peptide, are both type of autoantibodies are used for the diagnostic marker of rheumatoid arthritis and its diagnosis. Even it is used for the prognostic purpose as well. The immunopathogenesis process is depicted in the images where all the process have been linked in stepwise manner. Along with the rheumatological complaint like polyarthritis, symmetric involvement, wrist joint involvement, knee joint involvement, the patient with rheumatoid arthritis has got n number of extra cardiac manifestations also. Like in cardiovascular system, there may be accelerated atherosclerosis, which can lead to a myocardial infarction or coronary artery disease. They may develop a pericarditis, which is many of the time may have a exudative variety. In eye, they may develop episcleritis, scleritis, keratoconjunctivitis sicca, peripheral ulcerative keratitis. In hematology, they may develop a amyloidosis or disease condition like a Felty syndrome, where there is a combination of splenomegaly, neutropenia and thrombocytopenia. They may develop a pancytopenia. In nervous system, they may develop a cervical myelopathy because of involvement of cervical C1 and C2 vertebra, which may lead to subluxation, which is seen in most of the patient with rheumatoid arthritis patient, mainly those who are involving the axial skeleton. They may develop a neuropathy in the form of compartmental syndrome like carpal tunnel syndrome or mononeuritis multiplex in the form of either hand drop or foot drop. They may develop a cutaneous nodule or pulmonary involvement in the form of Kaplan syndrome, which is having a pneumoconiosis. They may develop a interstitial lung disease. They may develop a pleural effusion, which is most of the time of exudative variety. They may develop a pulmonary nodule. In skin, they may develop a rheumatoid nodule or vasculitis. All the articular and extra-articular manifestation of rheumatoid arthritis are depicted in the table and pictorial image. Now we will see the different categories of drug which are used for treating rheumatoid arthritis. These are mainly divided into disease modifying anti-rheumatic drug, which is called as DMRDs. These drugs are aimed to slow down the progression of disease by modifying the underlying immune system dysfunction. Biologic DMRDs, these are the targeted therapies that block the specific molecule involved in the inflammatory process, like tumor necrosis factor inhibitors, interleukin inhibitors, B cell depleting therapy, etc. There is another one group of drug which is called as a JAK inhibitor, a new class of drug which is an oral medication that work by blocking the specific enzyme involved in the inflammatory response. Fourth category is corticosteroid or steroids. These are anti-inflammatory drugs which are used for providing short-term relief of symptom and flare-up of disease condition. Fourth category is corticosteroid or glucocorticoid. These are group of drugs which are called as a anti-inflammatory drug which are used to provide short-term relief of symptom and flare-up of diseases. So this image is depicting the different group of drugs which are used in treating rheumatoid arthritis depending upon the patient's disease condition, associated comorbid condition and stage of the disease and organ system involved. These drugs to be chosen accordingly. So corticosteroid seems to be a cornerstone in the treatment of rheumatoid arthritis. Then methotrexate is also important primary drug. If patient respond to drug like hydroxychloroquine or methotrexate over a period of 1 to 3 months, it is well and good. Or if there is any contraindication to use methotrexate, you can have some other option like using sulfasalazine with leflunomide. If patient respond to that, you continue same medication. You can add additionally glucocorticoid as and when required depending upon the flare-up of symptom. Then if patient doesn't respond to this basic therapy like methotrexate and steroid, you can add another drug which are there in the biological DMRDs in the form of either or JAK inhibitors. So these are the different options of drug which are used depending upon the response to the primary or basic drug therapy in the patient with rheumatoid arthritis. The protocol of using or changing different drug combinations are depicted in the images. Now we will see the another autoimmune disease that is called as a systemic lupus erythematosus. Systemic lupus erythematosus is one of the more common seen disease condition in the clinical practice among rheumatological disease condition after rheumatoid arthritis. They usually present with tachypnea, non-specific symptom, fatigue, pleural effusion, different type of skin involvement in the form of erythematous rash which is there on exposed area which is getting exposed to the skin sunlight, butterfly rash which is erythematous type which is there over the cheek. Then there may be a non-specific symptom like weight loss, fatigue, fever, infections, arthritis, emotional liability, hematological different diseases, neurological symptom in the form of psychosis, anxiety, hematological cardiovascular manifestation like Raynaud's phenomena, pericarditis, vascular inflammation. They may have a important organ involvement in the form of lupus nephritis, which may present in the form of proteinuria or hematuria, nephrotic syndrome or nephritic syndrome. So many organ system, many tissues are getting involved in patient with systemic lupus erythematosus, start from dermatological disease condition, cardiovascular, pulmonary, gastrointestinal, neurological and nephrological system. Now we will see the management of systemic lupus erythematosus. Diagnosis of systemic lupus erythematosus is mainly symptom based and require an interdisciplinary approach depending upon the organ involvement. Patient with SLE should be referred to qualified medical specialist with long-term experience in the form of treatment of this disease condition or dedicated SLE centers. The treatment of SLE require to be monitored by a specialist with regular follow-up to be observed and response of the treatment also, to avoid the treatment related adverse effect or its complication or drug interaction and immunosuppression. Patient with SLE as such, and because of drug itself, they are prone for getting n number of infection because of immunosuppressed state. They may have a bone marrow suppression, they may have a involvement of renal or hepatic dysfunction. The treatment of SLE mainly targeted toward reducing complication using a minimum drug with minimum side effect, that too cost effective. The first line drug for SLE are hydroxychloroquine, sometimes non-steroidal anti-inflammatory drugs, glucocorticoids, and drug disease modifying drug like a methotrexate, mycophenolate mofetil, or cyclophosphamide. Biological therapy like rituximab, belimumab, which is monoclonal antibody that target the B cell activation factor, are also required depending upon the disease condition and state. In patient with stage 3 to 4 lupus nephritis, they may require a combination of drug like glucocorticoid, mycophenolate mofetil, cyclophosphamide, or azathioprine. In refractory cases, calcineurin inhibitor like a cyclosporin A, tacrolimus, or rituximab, which is anti-CD20 cell antagonist or immunomodulator combination, also may be required. The treatment strategy for SLE should be comprised not only on preventing measure but also treating the comorbid condition and disease condition like infection or cardiovascular event as well. Now we will see the third disease, that is the antiphospholipid syndrome, which is called as APS. Is an autoimmune disorder characterized by venous, arterial and microvascular thrombosis or pregnancy related complication in the form of recurrent spontaneous abortion. Antiphospholipid syndrome is characterized by immune system producing antibodies that attack phospholipid, which is essential component of any cell membrane. These autoantibodies causes blood clot to form in the arteries, vein. These blood clot can form in the leg in the form of deep venous thrombosis, or in the lung in the form of pulmonary embolism, and in the kidney and spleen as well. The clot can lead to deep venous sinus thrombosis, pulmonary thromboembolism, myocardial infarction, or acute ischemic stroke like condition. During pregnancy, antiphospholipid syndrome also causes miscarriage or stillbirth. Antiphospholipid syndrome mainly diagnosed on the basis of different types of antibodies which are detected in the laboratory. These are antiphospholipid antibodies. These are mainly beta-2 glycoprotein 1, prothrombin, annexin AS. Antiphospholipid syndrome is associated with anticardiolipin antibodies, beta-2 glycoprotein 1 antibody, and lupus anticoagulant, which can cause prolongation of phospholipid dependent coagulation assay like a activated partial thromboplastin time. So mainly laboratory profile required to be done for patient with APS is lupus anticoagulant, anticardiolipin antibodies, IgG or IgM, and anti-beta 2 glycoprotein. High doses of glucocorticoid, anticoagulation in the form of either heparin or warfarin depending upon gender or pregnancy should be chosen. Aspirin, plasma exchange, or sometime immunoglobulin or rituximab or eculizumab. These are the immunomodulator drug which are sometime required to be used in patient with antiphospholipid syndrome. So in clinical practice, when to consider that patient has got antiphospholipid syndrome. So unprovoked, unexplained stroke, unprovoked, unexplained pulmonary embolism or deep venous sinus thrombosis, or in pregnancy, if there is a miscarriage more than 14 weeks or less than more than 10 weeks in 2-3 times, or there is a evidence of preeclampsia or eclampsia associated with this stillbirth, should be considered strongly for probability of having antiphospholipid syndrome. In this situation, you should go for basic investigation in the form of blood sugar level, complete blood count, C-reactive protein, and specific investigation in the form of anti-cardiolipin antibody, anti-beta 2 glycoprotein, and non-specific inhibitor or lupus anticoagulant. So primary and secondary APS are depicted in the table. Primary APS associated without associated with other collagen vascular diseases or autoimmune disease condition, and secondary APS is usually associated with either systemic lupus erythematosus, rheumatoid arthritis, systemic sclerosis, Behcet disease, temporal arthritis, or Sjogren syndrome. The references are depicted in the table. Now we will see the comparative investigation which are required to diagnose these different disease condition. First, if you see rheumatoid arthritis, what we require is a basic complete blood count, erythrocyte sedimentation rate, C-reactive protein, rheumatoid factor, anti-CCP or ACPA, and imaging and other organ system investigation are as and when required. Blood sugar, renal function test, and liver function test are the basic investigation required to be done for all autoimmune diseases in present discussion, namely rheumatoid arthritis, systemic lupus erythematosus, and antiphospholipid syndrome. Complete blood count, CBC, ESR, and C-reactive protein, blood sugar, renal function, and liver function test are required to be done in the beginning as well as to monitor the drug therapy and progress of the disease in this disease condition. For systemic lupus erythematosus, additionally, we require to do a anti-nuclear antibodies, ANA, or anti-dsDNA, complement C3 and C4, urinary analysis, protein creatinine ratio, etc. Imaging as and when required depending upon the organ system involved in the systemic lupus erythematosus. In antiphospholipid syndrome, we may require to do additional lupus anticoagulant, anticardiolipin antibodies, or beta 2 glycoprotein 1, IgG or IgM. This investigation required to be done in the beginning of this disease condition at the time of diagnosis, as well as you may require to repeat few of these investigation as and when you require, or to assess the progress, complication, or to monitor adverse drug reaction associated with the therapy which is used for treating this disease condition. Now in total we will see all the group of drugs which are used in treating all these three disease condition, that is rheumatoid arthritis, systemic lupus erythematosus, and antiphospholipid syndrome. So this drug therapy mainly categorized or classified into two parts. That is, one is a disease modifying anti-rheumatic drug, biological anti-rheumatic disease modifying anti-rheumatic drug, or targeted synthetic DMRDs. Non-steroidal anti-inflammatory drug may require to be used for treating minor ailment in rheumatoid arthritis and systemic lupus erythematosus to reduce the joint pain, etc. Glucocorticoids are used for short-term period in either of these disease condition. Hydroxychloroquine and sulfasalazine are mainly used in patient with rheumatoid arthritis. Methotrexate, loflunomide are often used in patient with rheumatoid arthritis. Baricitinib, tofacitinib, rituximab, etanercept, infliximab, tocilizumab, and abatacept. These are the drugs which are used in treatment of rheumatoid arthritis depending upon the disease condition and response to the primary regime. In patient with systemic lupus erythematosus required to be treated with glucocorticoid in short-term duration, they may require to use hydroxychloroquine, mycophenolate mofetil, azathioprine, cyclophosphamide, rituximab, and belimumab depending upon the stage of disease and renal involvement and contraindication for using this therapeutic modality. In patient with antiphospholipid syndrome, you may require to use aspirin, heparin, oral anticoagulant in the form of warfarin, or sometimes you may require to use rituximab in patient with secondary APS or overlap with systemic lupus erythematosus. This table is depicting the comparative use of different drugs used in treatment of rheumatoid arthritis, systemic lupus erythematosus, and antiphospholipid syndrome. These drugs are non-steroidal anti-inflammatory drug, glucocorticoids, conventional disease-modifying anti-rheumatic drugs, biological or targeted therapy, anticoagulation, and antiplatelet. To be specific and concise, antiplatelet and anticoagulations are mainly required for patients with antiphospholipid syndrome. For rheumatoid arthritis, commonly drug used for flaring up disease condition, you require to use glucocorticoids along with conventional DMRDs in the form of either SCQs, loflunomide, methotrexate, or hydroxychloroquine. Sometimes you may require to use drug like a tumor necrosis factor inhibitor or IL-6 inhibitor or B-cell depletion therapy in the form of rituximab. In SLE, you require to use non-steroidal anti-inflammatory drug to relieve or alleviate the symptom of joint pain in short-term duration. Glucocorticoid also to be used as a bridging therapy till the disease modifying drug start their effect, and sometimes you may use it to repeatedly you require to use it them when there is a disease flare up, mainly renal involvement. SCQ also can be used in patient with SLE along with azathioprine, mycophenolate mofetil, cyclophosphamide depending upon organ and system involved. B-cell depletion therapy, rituximab, belimumab, these are the other immunomodulatory drugs which are used in treatment of SLE in certain refractory disease condition. Low dose aspirin is also recommended in patients with high risk antiphospholipid positive patient or patient those are in having a overlap syndrome with the antiphospholipid syndrome. To summarize whole session or to conclude that basic all autoimmune disease has got different background of HLA predisposition, genetic predisposition, and environmental factor. They may come together at different phases of time, and they trigger the autoimmune mechanism and the disease process. Rheumatoid arthritis and systemic lupus erythematosus are the important significant disease condition which causing the disability and morbidity among patient with rheumatological disease manifestation at large. Timely management, multidisciplinary and integrated management approach is mandatory for the better outcome of these common rheumatological diseases. Effective management of rheumatoid arthritis, SLE, and APS require understanding of their immunopathogenesis, overlap pathologies, individualized therapeutic option, considering associated comorbid condition and organ system involved. Rheumatoid arthritis management mainly emphasizes to control the joint inflammation. SLE demand more multi-organ targeted and tailored immunosuppression. Antiphospholipid syndrome focuses mainly on the thrombotic pregnancy related disease prevention, and they require anticoagulation. Sometimes antiplatelet agent also work for patient with the antiphospholipid syndrome. The comorbid burden, particularly cardiovascular disease, osteoporosis, is significantly seen in all these three conditions, which mainly require to be focused and should be taken care of. Adverse drug effect, drug interaction, immunosuppression, infection, bone marrow suppression, renal and hepatic dysfunction are the limiting factor for all these rheumatological disease condition which we discuss. These are the important limiting factor for medical management in long run. Cost effective, newer molecules, newer modality are the futuristic option for treatment and management of this chronic disabling rheumatological diseases at large. Thank you so much for listening patiently. There is no conflict of interest in this presentation. I hope in this small presentation in short duration I could able to cover the majority aspect of this commonly seen rheumatological diseases like rheumatoid arthritis, systemic lupus erythematosus, and antiphospholipid syndrome. Thank you once again.
Okay, good afternoon once again. We are going to continue with our sixth speaker. He is no other than Dr. Ademeyo Ogu Olua. He is the head of Department of Medicine at the General Hospital Ijedi, Okorodu, Lagos, with over 2 decades of experience. He specializes in infectious and chronic diseases, including HIV, tuberculosis, malaria, and Ebola. Has served as an infectious disease consultant, implementing national guidelines, building staff capacity, and instituting best practices to improve health outcomes. Dr. Ademi also works as development and health and safety consultant, producing health education content and advising on work health standards. Welcome, Doctor.
Thank you. I want to thank the organizers for the opportunity given to be here today and to speak on this topic that affects us all serially and regularly. So, post-stroke critical care. I would like to give a background information so that we understand where we're coming from and where we're going to. So, in Nigeria, stroke is a big deal, especially on the streets. And so, on the streets, in layman's terms, when somebody has a stroke, because Nigeria is steeped heavily in spiritualism and religious beliefs, the first thing they say is, oh, he has stepped on something, or the enemies have shot an arrow and he couldn't avoid it. And so that's the belief on the streets. So this has impacted and influenced the presentation, the mode of care in the hospitals. So the first case study I like to use start off with is a lady, 70-year-old lady, forgive the font size, who was poorly managed with hypertension and diabetes. She presented with right hemiparesis, a blood pressure of about 190, 120 thereabouts. She had facial deviation, slurred speech, which all occurred while she was at breakfast. She was present at the institution and she was managed as per protocol. She regained full mobility and full functions within 48 hours and she was discharged to the neurologist. This same lady presented 5 months later with constant repeated unremitting seizures, a Glasgow Coma scale of 3. And the history we got was that all of this started while at breakfast again. She was admitted and managed as per protocol. She had a CT of the brain which echoed and repeated the same issue, that background cerebral atrophy, and she had cerebral infarction. Case 2 is a 55-year-old male who was discovered with repeated seizures sometime in the morning. We don't know for how long he had been unconscious, having seizures. And so somebody chanced upon him and found him having repeated seizures. And he presented within 6 hours of discovery at the hospital with a Glasgow Coma scale of 5. His blood pressure at presentation was about 220, 140 centimeters of mercury. He had a pulse rate of 103. Respiratory rate was 24 cycles per minute, and saturated oxygen was 98% on room air. He was managed as per protocol. A CT, non-contrast CT scan of the head, about 72 hours later, revealed multiple cerebral infarcts with background brain atrophy and bilateral parietal small vessel ischemic changes. He regained 48 consciousness after about 48 hours on management with residual hemiparesis and some altered personality. Now, stroke, according to the American Heart Association, is defined as an acute episode of focal neurological dysfunction lasting longer than 24 hours. It's a leading cause of death and long-term disability worldwide. 89% globally of strokes are found in low and middle-income countries, of which the majority of such countries are in Africa and Asia. The burden is growing in Africa and Asia, shaped by multiple transitions of epidemiology and uneven access to prevention, acute care, and rehabilitation. Ischemic stroke occurs more frequently, considered about 87% of all stroke types. The hemorrhagic variety causes more fatalities and lost disability adjusted life years. It's far less common in high-income countries based on obvious reasons. So it's known that the second leading cause of death and the third leading cause of disability globally. About 1 in 4 people are said will have a stroke in their lifetime. 53% of strokes occur in individuals under 70, and we've had a spike during economically challenged periods in country. In Nigeria, our prevalence rate ranges from 0.36% to over 13%. A siren study involving Nigeria and Ghana revealed that 68% of stroke types were ischemic, 32% were of the hemorrhagic variety. And it's an expensive disease to manage in country. The minimum wage in Nigeria is less than $50, but it costs about $300 to $7,000 a week to manage stroke acutely in the hospitals. So stroke is a heterogeneous syndrome arising from distinct vascular insults to the brain. It triggers an energy crisis in affected brain tissue, leading to excitotoxicity and cell death. Across both types, there's inflammation, blood-brain barrier disruption, and oxidative stress driving secondary injury and edema. In the acute stages, which we try to take care of in our facility, it's known that the first 7 days are crucial. So the first stage is the hyperacute or the pre-hospital stage, and arrival to emergency departments is minutes to hours. Early in-hospital presentation, first 24 hours. Early complications prevention is usually seen within the first 24 to 72 hours. Transition to subacute phase is 3 to 7 days, and early rehabilitation and discharge planning, 7 to 14 days or earlier. Now, in facility, what happens when such a patient presents? First is that there's activation of the stroke protocol. Then there's acute stabilization, airway, breathing, and circulation, thanks to our trauma and multiple trauma presentation earlier. He has elicited a lot of this. Blood pressure management is vital and is tailored to the stroke subtype. Use of thrombolytics and contraindications, terminating fevers and seizures, because we found out that fevers compound the management and the outcomes. NPO initial, because a lot of them have challenges with swallowing, which occurs pre and after acute care. There's oxygen supplementation if the saturated oxygen falls below 94%, and a complete workup, including an ECG, echocardiogram, and neuroimaging, is vital and important. We try to manage innovative use of available resources because we work in resource constrained environments, and we work in the suburbs where we don't have the full complement of staff, manpower, and equipment. There's a continuous 4 to 8 hourly patient review by the casualty officers and departmental physicians. External consulting with related consultants and experts in regional, secondary, and tertiary facilities helps in our acute stages and eventual outcomes. Early rehabilitation starts as soon as the patient presents, because we realize that within the first 72 hours, a lot of function can be regained and reversed once we start early physical, occupational, or speech therapy. So we try to work to prevent early complications, aspiration prevention, deep vein thrombosis. A lot of those who come down with CVAs are elderly, and many of them already have challenges with mobility. So with institute DVT prophylaxis, chemotherapy, mobilization, compression, strict glycemic control monitoring, we manage dyslipidemia. Management of cardiac arrhythmias and myocardial infarction is also instituted based on stroke type. Education and re-education of all nurses, doctors, and those who work in emergency units is taken repeatedly and emphasized per patient. There's increased awareness of stroke signs and symptoms. Hub and spoke model of care is instituted. So we don't work in isolation. We have challenges. We reach out to neighboring institutions to gain function and intervention. And like we said earlier, planning post-rehabilitation starts immediately. In-house. So we went and looked back over the last couple of years and did a randomized study of 20 patients. And we found out that we had a male to female ratio of 1 to 2.3%. Predominantly more females have stroke, present with CVAs than males. The mean age at presentation in facility was found to be 60.6 years. The mean time of presentation at the hospital was 76 hours after the initial assault. Very few patients present within the first 24 hours. The door-to-needle time average in our facility was about 48 to 70 hours. The standard is supposed to be less than 4.5 hours. Complications, the male had more complications and negative outcomes compared to the females. And outcome at presentation, those who are less than 60 years of age had more complications and mortality. Frequency of CVA was found to be more in those who had comorbid conditions of diabetes and hypertension. Our CVA type, we had 90% more ischemic variety than the hemorrhagic variety. And for those who had ischemic CVAs, 90% had more complications, but our sample size is really little to mix it. Post-stroke care. So like we said earlier, significance of post-stroke care in reducing mobility and mortality is vital to us. And it always ensures that we take care of everything from the pipe to the penumbra And also all that will ensure that the patient has a remarkably good outcome, and structured post-stroke care will reduce such risks. Recurrence is a significant concern. Post-stroke care focuses on controlling the underlying risk factors that cause the stroke in the first place. And this includes strict management of blood pressure, cholesterol, diabetes, and other risk factors, which are the primary drivers of CVA. Secondary prevention lowers risk. Antithrombotic therapy is important, mostly for patients with ischemic stroke. Medications of blood pressure clot preventions are the cornerstone of care. Judicious use of antiplatelets is instituted. Neuroplasticity is vital, and we try to ensure that for every stroke patient who presents within this acute stage, we work towards helping the patient to have to gain back a lot of neuroplasticity and brain functioning. Because we found out that it's highest in the first few months after a stroke. And if we intervene early, we help to promote early neuroplasticity and return to stroke status. Early intensive rehabilitation, including physical, occupational, and speech therapy, is vital. This proactive approach significantly improves the patient's quality of life and their ability to be independent. Cognitive and emotional health. Addressing post-stroke depression is important. Most of our stroke patients who present, we found out that over 90% of them had eventual depression, cognitive impairments, and caregiver burden improves overall outcomes and adherence to rehabilitation. In our facility, once a person presents with CVA, we not only take care of that patient, we also take care of the caregivers, because we have had in situations where the caregivers eventually came down with some form of disease or illnesses while taking care of the patient, which further worsened and impacted on the survival, the primary patient. Social integration is important. Quality of life. Many studies have found out that among stroke survivors was poor, indicating substantial impairment in overall functioning and social reintegration. At 1 month post-stroke, a large majority of survivors had severe depression. Now, the first case we presented earlier of the lady who had repeated CVAs while at breakfast, we eventually came to find out that a doorknob phenomenon took place where the husband came and said, I want to discuss what has triggered my wife's repeated stroke. And we're interested. And it says she has some family crisis. And anytime it comes up, her medication use is impacted, her blood pressure goes up, and she develops another crisis. So we come to find out that a lot of them have issues with mental health. Regional considerations. We work in a environment, just like many of us also. And there is the ideal and there's the actual. We have limited financial resource, which impacts on our care. Out-of-pocket payments is heavy in our environment, and the insurance coverage is just about 10% nationally in Nigeria as of now. So most of our stroke patients have a high burden of out-of-pocket payments. We all have to pitch in, take care of this. Poor road networks impact our stroke acute care. So we said the door to city time is about 72 hours in facility. Because we don't have it in facility, they have to be referred out. Out-of-pocket challenges adds the constraints, because they have to first source for the finances before they now go far, about 20 kilometers away, to have the CT scan done, returning back to care and waiting to get the results also impacts on care. Access to thrombolysis is challenging because, like we said, most of our stroke patients present after 72 hours, not within the time frame of 13.5 hours. but we do what we can do, and we've had wonderful outcome for most of our stroke patients. Personnel. So this is a huge challenge globally, and we also have our own challenges in-house. High staff attrition, limited neurologists in country. We have about 80 in Nigeria, taking care of a population of about 220 million people. So it's one neurologist to 2.4 million people. Education is vital. Impacts of the late presentation limits the outcomes and gives a worse poor prognosis. The main presentation time for CT imaging was 70 hours. Time requirement for presentation was not fulfilled by any of our patients who had an ischemic stroke arrived for imaging later than those who had an intracerebral hemorrhage or subarachnoid hemorrhage. Now, our success story in a we have tried to change the narrative and change things, and we realized that the gap between the town and the gown was too wide. It's as wide as the distance between the ocean front in Gambia from the east to the west. So realize that the healthcare personnel and those in the hospital are super trained, but the community knows next to nothing about it, and they are steeped in so much spirituality, suspicions, and so on and so forth. So we took it upon ourselves to go into the community regularly and educate them. So we start education from the grassroots. We start the education and continue the education through the primary schools, teaching them about their health, ownership, and intervention types. This has helped to reduce the length of time a stroke patient used to present with them versus now. So it's shortened, but we can still do better, and we're still doing more. Then we also realized that continuous community engagement and educational campaign has also helped. So now they are aware, they are better educated, and then once something happens, those who are around them recognize the signs and start to institute appropriate interventions immediately. So like I said, we celebrate, so we've developed an SDU in the hospital, a service delivery unit, which is responsible for going out on educational campaigns and sensitization campaigns into the community. So for every World Health Day, there is something to do and to deliver. So we meet them at their parks, at where they work, in the market, we go around. We also go to the primary schools to ensure that education starts from that early. We walk it up all the way up into the communities, up to the tertiary institutions. And I like something that happened when I came into Ghana, which further reinforced and educated me. So when we came to the Gambia on Tuesday night, I love the fact that you have so many taxis and they have so many lessons, life lessons inscribed on their windscreen and bodies. And I saw one of them and it was profound. And it says, life is circulation. Thank you for listening.
Thank you very much, Madam Moderator and Doctor.
Thank you very much, Dr. Ademi.
Asking this question because
the presentation was insightful. Thank you very much, Dr. Ademi.
And follow up.
Our next presenter is going to be Dr. Nabil Gerard. He is a consultant respiratory physician at Gloucestershire Hospital with an extensive experience in clinical practice, research, and medical education. He has held key leadership roles, including Secretary of the Research Committee of the British Thoracic Society. He's been Program Director and Chair of the Southwest General and Acute Medicine Training Committee. He is also the Chair of the Committee of Physicians at Bristol Royal Infirmary, Southwest Regional Advisor for the Royal College of Physicians, and also President of the Bristol Medical Chirurgical Society. He is also a prolific researcher and author and has contributed to numerous manuscripts, chapter textbooks, articles, and serves as the editor-in-chief of the West of England Medical Journal. His topic of discussion today is going to be idiopathic pulmonary fibrosis, a deadly lung disease. So in the presentation.
Good morning, Senator Kalaj, Many thanks, Dr. Kingsley Baskararaj, and many thanks for the Merck Foundation for inviting me to give this presentation. I will now start sharing, and I will share my presentation. I'm asked to talk about lung fibrosis. My name is Dr. Nabil Jarad. I'm a consultant physician at Gloucester Royal Hospital. And as I said, I will share to you my thoughts about lung fibrosis. This is the hospital, which is two parts. The first on the left is the Gloucestershire Hospital, and the second one on the right, it is Cheltenham General Hospital, and these two sites are part of the same hospital. Lung fibrosis initially thought to be an uncommon condition, but we, as a respiratory physician, see it not infrequently. The prevalence or the epidemiology is around 75 per 100,000, and this is about interstitial lung disease, does not include post-TB fibrosis. There are several types of interstitial lung disease. The commonest is what we call idiopathic lung fibrosis, or we call it sometimes usual interstitial pneumonitis. We call it UIP, and non-specific interstitial pneumonitis, and I will make the distinction in a minute. And the prevalence of that is about 30 per 100,000. Sarcoidosis, which is perhaps commoner in your part of the world, and is about 12 per 100,000. And there are other lung fibroses associated with connective tissue disease, which is less common. And the two conditions I would like to cite are rheumatoid arthritis and systemic sclerosis. For all interstitial lung disease, the cardinal test is high-resolution CT scan. You may be guided to it by looking at the chest X-ray and listening to end inspiratory crackles by auscultation, but the confirmatory test is high-resolution CT scan. It is difficult to know where the process of lung fibrosis starts, but it is generally accepted that a lung injury, often it is an infection, happened to start with. The non-fibrotic stage of the disease comes into various inflammatory changes. And this is particularly important. The non-inflammatory or the non-fibrotic change can be treated or can be stopped by a variety of medications, which are anti-inflammatory and immune modulators. However, when the inflammatory is followed by fibrotic changes, the treatment currently does not reverse the condition, and the importance of the treatment is to stop the fibrotic changes from progressing and from engulfing the lungs. So the inflammatory non-fibrotic change can be treated and can be reversed, but the fibrotic change can be treated, and the main aim of the treatment is to stop the decline in lung function tests. I would like now to go into the variety of usual manifestations of lung fibrosis, and for every type of lung fibrosis, we look into the clinical side, prognosis, management, and the likelihood of prognosis to death. As I said, the commonest condition is idiopathic pulmonary fibrosis, and this is a disease of the elderly. It starts often after 50 years of age, and in fact, in our neck of the woods, it starts normally after 65 years of age. It is a male predominant disease seen in people who smoked or are current smokers. On CT scan or on X-rays, it mainly affects the lung bases. Not everyone has finger clubbing, but it happens in a proportion of people. It has a poor prognosis. Most people die within 3 to 4 disease. People who hold poor prognosis is when the diagnosis is in old age, in male, and when people have a well-established lung fibrosis, the so-called honeycomb manifestation and the traction bronchiectasis. These will be indicating a poor prognosis. The management of idiopathic lung fibrosis is smoking cessation, management of breathlessness with opioid anxiolytic agents like diazepam, and with oxygen therapy. Even with the development of modern treatment, this is really the gold standard of treatment of lung fibrosis, managing symptoms and providing oxygen therapy. Antifibrotic treatment, I will be talking about that, and I'll be talking about pirfenidone and nintedanib. Cough management and fatigue management is important. We refer people for the same pulmonary rehabilitation program that will refer our COPD patient. We seek palliative care input for a holistic management of the patient. Proportion of patients who go to death with usual interstitial fibrosis is very high, and people die within 3 to 4 years. This is the commonest form, and this is perhaps this slide particularly would summarize the major manifestation and major management of the disease, which is the commonest and the disease that carries worse prognosis. Interstitial lung disease associated with rheumatoid arthritis normally is seen initially in people who have a manifestation of rheumatoid arthritis, normally deforming, but not necessarily patient with rheumatoid arthritis. Some people say that lung fibrosis precedes this group of the joint manifestation, but this is not quite clear. The chest changes is very similar to the previous condition, except that it tends to happen in the apices and on the bases of the lungs. It has more ground glass opacities, something we call non-specific interstitial lung fibrosis. So unlike the previous idiopathic lung fibrosis, which is a basal disease and tend to be well established, lung fibrosis and rheumatoid arthritis can have ground glass opacities, as you can see down here, and can happen in the upper part and middle part of the lungs. Prognosis is also in old age, if the manifestation, male predominance, if it has well-established manifestations like honeycomb formation, and if the FEV1 or the FVC is reduced below 70%. The treatment is to manage breathlessness and cough as we did in the previous disease. But unlike the lung fibrosis, anti-inflammatory treatments do work. In lung fibrosis here, anti-inflammatory treatment such as steroid do not work, and it is normally advised against. With this condition, prednisolone and methotrexate, mycophenolate, and azathioprine are of help. If the disease is well established, nintedanib will be offered. Unlike the poor prognosis in idiopathic lung fibrosis, proportion of patients who progress to death is much less at 30%. Interstitial lung fibrosis associated with systemic sclerosis have many similarities with those with rheumatoid arthritis. You have manifestations of lung fibrosis with fine crackles, but also manifestations of systemic sclerosis, such as skin changes. This is tightness around the joints, Raynaud's phenomena, vasculitic changes, and gastroesophageal reflux disease because of the disease affecting the esophagus. The chest imaging is very similar to rheumatoid arthritis, is non-specific interstitial pneumonitis, as you can see. The prognosis is a lot better than previous condition. The 10-year survival, nearly half of the populations. The predictor of progression to death is black race, male gender, impaired lung function test, and some antibodies factors. If the people have severe lung changes, and if they have pulmonary hypertension, which can happen with or without lung fibrosis, these are all poor prognostic factors. The treatment is mainly really anti-inflammatory treatment. We give mycophenolate, azathioprine, rituximab, and tocilizumab. And if there is a fibrosis, nintedanib is proving to reduce the decline in lung function test. Only 40% progress to death. I would like just here to make the comment that methotrexate and azathioprine are now thought to less likely induce lung fibrosis themselves. So if you find a person with lung fibrosis and on methotrexate, it is very likely that the condition is the cause of lung fibrosis rather than the drug itself. Sarcoidosis is a unique condition, and unlike previous condition, the presence of fibrosis and changes of fibrosis tend to be very inorderly. So unlike the subpleural fibrosis and interstitial here, the fibrosis tend to be much more of a conglomerate fibrosis affecting the upper lobe, causes traction bronchiectasis, cystic changes, and pleural cap. As you can see in this X-ray, with burnt out fibrosis or sarcoidosis, there are calcifications affecting the lymph nodes, something we call an egg shell manifestations. The prognosis is reasonably good because there are preservation of good parts of the lungs, and the predictor of prognosis, poor prognosis, is the black race. The management in the majority of people is to monitor patient, and corticosteroid, azathioprine, methotrexate, and rituximab can be given in people who have active sarcoidosis rather than in people who have burned out sarcoidosis. Proportion of patients who go to death is 1 in 6 approximately. The condition of hypersensitivity pneumonitis is of a great interest in the UK. It used to be called fibrotic hypersensitivity pneumonitis, or sometimes we call it extrinsic allergic alveolitis, which is really a misnomer of this condition. And clinically, with the history, there is a prolonged exposure to known agents. However, in some patients, and that's very important to note, that there are no known agents. Patients come with upper lobe disease and radiological manifestations, but there is nothing in the history to indicate what kind of agent there is an exposure to. It is an upper lobe disease and has ground glass opacity before it becomes fibrotic. The prognosis is quite good normally. However, if there is no known agent and if the disease is progressive and if there are fibrotic changes, these are all a predictor of progressive to death. The management, if you know the agent, avoiding of exposure. In the UK, this is the hardest bit, especially if the exposure is a cockatiel or bird of paradise or pigeons. People may will find it very hard to avoid them. Anti-inflammatory agents are the next step, and nintedanib is good for progressive lung fibrosis. And very, very few people die from extrinsic allergic alveolitis. So by and large, it is a treatable disease. Finally, the other type of fibrosis is the so-called unclassified, non-specific interstitial lung disease. It's a disease of the upper airways. There is no factor you can identify. It can cause fibrosis, but in the majority of people, you found ground glass opacities. And the ground glass opacities, in general, on CT scan, is a treatable condition with anti-inflammatory medications. And the treatment is often supportive. You can give antifibrotic treatment when there is a well-established fibrosis, and both pirfenidone and nintedanib are effective. When do we do bronchoscopy to make a diagnosis of lung fibrosis? Given bronchoscopy now become extremely rare to make a diagnosis, CT scan is sufficient. However, bronchoscopy can be indicated in patients who have unclear diagnosis. If there is a possible infection like this, or possible cancer, which is not an interstitial lung disease, but fibrosis can be used to either take a biopsy or to quantify cell content, which will predict the response to steroid. So in bronchoalveolar lavage, the higher the lymphocytes, the more likely that the patient might respond to corticosteroid, provided that the patient has interstitial lung fibrosis rather than cancer or an infection. Transbronchial biopsy, it can be employed to take a sample, and sometimes thoracoscopy and lung biopsy can be employed in patient when the manifestations are unclear and when there is a clear need to take a biopsy to rule out treatable other conditions such as infection, cancers, or granulomatous lung disease. Nowadays, cryobiopsy is a form of biopsy that can be employed to take a big sample of the lung, and the cryobiopsy is have the advantage of taking a big sample compared, this is transbronchial biopsy. It has the complication of bleeding, but on the whole, cryobiopsy, if it's employed, it can take a big chunk and it is relatively safe. I would like now to move on to the treatment. And I would like to start with the study that called the Panther study, in which have really changed our practice in patients who have idiopathic lung fibrosis or usual interstitial pneumonitis. In the Panther study, which is being published now about 14 years ago, there was a 3-arm in which in arm 1, prednisolone, azathioprine, and N-acetylcysteine were given. Arm 2, N-acetylcysteine given alone, and arm 3 was placebo. The study have stopped halfway through because of safety reason. Arm 1 and arm 3 were compared, so this is the combined therapy with placebo, and they were found that mortality rate and progression to hospitalization was a lot higher in people who have been given combined treatment compared to placebo. And in here, this is the bottom graph on the right, time to death and hospitalization was immediately higher in the combination therapy compared to placebo. And that means that people should not be given prednisolone, azathioprine, and N-acetylcysteine alone. Can I say that the combination therapy and the completion of the Panther study has found that in arm 2, N-acetylcysteine was ineffective in patients with interstitial lung disease. So currently, there is no anti-inflammatory treatment to people with well-established idiopathic lung fibrosis. A supportive therapy, as I said, it is hopefully available everywhere, is probably the cornerstone of treatment of the majority of the lung fibrosis. Cough can be given, and the cough can be dry, hacking, and sometimes it actually produces thick and tenacious sputum. Dextromethorphan containing cough linctus can be given. If people have colored sputum, a course of antibiotics can help. Breathlessness can be treated by either oxygen therapy, opioid, or anxiolytic agents. Pulmonary rehabilitation can reduce breathlessness, but only for a short period of time. The other two symptoms are fairly resistant to treatment, and that is fatigue and weight loss. And currently there is no treatment present, and the only thing will be an adjusting activities to adjust for fatigue, and weight loss is for an attempt of high calorie nutritional therapy. What about antifibrotic treatment? Antifibrotic treatment is fairly expensive, and the main aim is to reduce the decline in lung function tests. In the UK, all patients with interstitial lung disease are discussed with the information available to them in specialist center by multidisciplinary team meetings where a respiratory physician, radiologist, physiotherapist, and nurses, as well as pharmacists, are present. And the drug is provided by certain centers and followed up by the central pharmacist to ensure that compliance is achieved and side effects are monitored. In the UK, forced vital capacity need to be between 50% and 80% of predicted, or it has a rapid decline of 10% within 1 year. Normally, it does affect the decline in lung function tests. The common side effect for pirfenidone is photosensitivity, and for diarrhea, for nintedanib is diarrhea. And we give people some precautions of that, as I mentioned in a minute. Pirfenidone is 200 milligram twice daily, and it does cause photosensitivity. And we advise patients to wear protective clothes, sunglasses, and sun cream, and not to expose to the sun. But as you can see in people who are susceptible, there is a prevention of decline or slowing down in decline in vital capacity. And this is the original study in 2016. The solid bit is pirfenidone and the light bit is placebo. And there is a difference, and the difference is encountered after 3 months of providing the treatment. Nintedanib, if you remember the cycle of pre-fibrotic and then fibrotic phase, is another mode of action, is initially anti-cancer treatment, and nintedanib can stop the non-fibrotic phase of becoming fibrotic. So it acts as an anti-inflammatory, but it also can stop fibroblast from producing fibers. So it does slow down the fibrotic changes, and it slows down the decline of lung function test by this particular phenomenon. As I said, the main side effect is diarrhea, and often this group of people are given medications such as Imodium as a protective agent and as a standby agent if diarrhea happens. And like pirfenidone, it does slow down the decline in lung function test. This is nintedanib, this is compared to placebo, and the dose either 100 or 150 milligram twice daily. The same effect is seen in systemic sclerosis and in patients with fibrotic component irrespective of the cause of lung fibrosis, and that is very encouraging. So we can give antifibrotic treatment even if we don't know the cause of fibrotic changes, and even if the patient has all kind of usual interstitial fibrosis like fibrotic changes. So it can be given freely to all people with lung fibrosis. When do we give prednisolone in interstitial lung fibrosis? We give it in non-specific interstitial pneumonitis, and when the CT scan show ground glass abnormalities. So it's not well established for, it's not for well-established lung fibrosis. This is my view of how to start. Steroid is to start 40 milligram once daily for 4 weeks, and after that reduce it quickly by 10 milligram every 2 weeks. So after 4 weeks, people start on 30 milligram for 2 weeks, then 20 milligram for 2 weeks, then 10 milligram as a maintenance dose. Reducing the dose below 10 milligram, and especially in responders, need to be done fairly carefully and need to be monitored by symptoms, lung function tests, and by radiological investigations, such as chest X-ray or preferably CT scan if available. If relapse happened after tapering the medication, then methotrexate and azathioprine can be considered as steroid-sparing agents. As I said, methotrexate and azathioprine are often unlikely to cause fibrosis themselves. An important component on lung fibrosis, and that is gastroesophageal reflux. This is a patient with lung fibrosis and hiatus hernia, and the hiatus hernia will dribble over the lung and often exacerbate lung fibrosis. That happens even in patients who are using proton pump inhibitors. So it happens even if the juice of the stomach is alkaline rather than acidotic, because pepsin can still go up and damage the lungs. And the treatment here is fairly hard. It is not recommended that surgical treatment can occur except in exceptional cases. And then here there is something called fundoplication, and that is kind of increase the strength of the esophageal abdominal foramen. But that is not something we use routinely. And the only thing we use is proton pump inhibitors on the hope that suppression of the acid will reduce the potency of pepsin of damaging the lungs. I would like just to finish by exacerbation of lung fibrosis. And this is a phenomena that we see in an acute environment. It is a serious complication. It's often induced by infection. A patient who is known to have lung fibrosis presents to an emergency department with acute increase of symptoms, breathlessness, cough, and fatigue. This diagnosis can be supported by new X-ray changes or CT scan changes, as you can see here. And often we have elevation in inflammatory markers such as ESR or CRP, as we do in the UK. The treatment of exacerbation of lung fibrosis is a supportive treatment by giving oxygen therapy in hypoxic patients. We normally start antibiotics, either intravenous or orally, depending on the compromise of the lung fields. The treatment is continued after discharge for 2 weeks with antibiotics. Any antibiotics will do. Prednisolone is given 30 to 40 milligram for 2 weeks. It is possible to give methylprednisolone during the acute stage in compromised patient. If patient need assisted ventilation or an intensive care, the prognosis is poor. You may wish to consider it if you feel that the patient have reversible component, but if the patient needed assisted ventilation or intensive care, it often carries a very high mortality rate. COVID can cause lung fibrosis, but unlike what was thought before, the COVID lung fibrosis is very rare and is often associated with people who needed intensive care at the COVID period. COVID pneumonitis tend to be much more of ground glass opacities rather than a well-established lung fibrosis. However, the disease is milder than what we thought, and often lung fibrosis can respond to treatment or resolve by its own. This is a patient with fibrosis with pneumonitis after COVID, and as you can see, there is widespread ground glass opacities, and they were treated, but 6 months after the treatment, only basal changes remain, and as you can see, the ground glass opacities have disappeared. Pirfenidone has been tested and nintedanib has been tested, but there are no solid criteria about their efficacy. Of course, you can start it if the patient have impaired lung function test and if there are no other treatment available. So I'll finish, ladies and gentlemen, with the conclusion. Lung fibrosis remains an unpleasant respiratory illness with potentially high impact, with breathlessness, disability, and cough. The diagnostic procedure remained high-resolution CT scan of the lungs. The mainstay of the management is supportive, normally cough, breathlessness, and oxygen therapy. The prognosis is variable between types of lung fibrosis, but it is generally poor for idiopathic lung fibrosis. We talked about exacerbation of lung fibrosis being a serious complication, but actually potentially treatable. And again, the treatment is with oxygen, antibiotics, and short course of steroid, normally 2 weeks. Antifibrotic treatment are available and promising, but they don't reverse the disease. It's given to people with impairment of lung function tests and with fibrotic changes. Thank you very much, ladies and gentlemen, and I hope to be present when the time for question and answer, but that will depend on the technology and with the ability to communicate. Thank you once more.
Hi everyone, I'm Dr. Faraz Ali, a consultant dermatologist based in Cardiff, Wales, UK. I would like to thank the Merck Foundation for kindly inviting me to talk about the impact of skin disease on a person's quality of life. A little bit about myself: I am a consultant in the NHS. but I also work as a research fellow at Cardiff University, where I've contributed to quality of life research for the last 13 years or so, and I continue to contribute to that field. I did a PhD on the impact of psoriasis on quality of life, but certainly I contribute to very different fields within quality of life, and I'll be talking a little bit about that throughout the presentation. So we all know, skin disease has a visible severity element to it, but what about the day-to-day life? What about the relationships? What about the psychological burden of skin conditions? And that's why I chose this diagram for the opening slide. It's an artistic representation of what it feels like to live with a skin condition, the sort of burning sensation that some skin conditions can have, makes a person feel like they want to tear their skin. And there's a lot of voices that need to be heard. There's a lot of stories about day-to-day impact of skin disease. So let's see, hopefully we can touch on some of this in the coming few slides. Just some disclosures in terms of conflicts of interest. Of course, I mentioned I work with Cardiff University Quality of Life team, and I'll be talking a little bit about the quality of life measures at Cardiff University, which I'm in charge of, but I'll be talking a little bit about the generic aspect of quality of life as well. So just a quick overview of the contents and what I will be covering today. We'll be looking at what exactly quality of life is, the impact, how we measure it, and then we'll look a little bit at case studies, in particular psoriasis and atopic dermatitis or eczema. These are the most common inflammatory conditions we see in our inflammatory clinics, certainly, and there's a lot of studies that have been done on these conditions, and I think it'd be a good model to use really to demonstrate the impact of skin conditions on people's lives. So what exactly is quality of life? And I have given similar talks many times, and I always like to, since COVID, I like to use this picture. This is a busy city center, which would ordinarily be bustling with people walking around, having fun, eating, drinking, engaging with each other. But COVID really took that away from a lot of people from the entire world, really, if you're looking at it from a social point of view. Of course, people suffered in different ways with COVID, and it impacted people in very significant ways, including, unfortunately, people who lost their lives. But for people who were socially isolating and staying within their homes, I think it gives a taste of what happens when you are unable to enjoy the things that you take for granted on a day-to-day basis. Being able to go out, going to the shops, going to do your favorite sports, going swimming, traveling, meeting people, meeting friends, maintaining relationships. These things, I think a lot of us began to understand the importance of during COVID. You start really appreciating these things that for many of us we might consider small or insignificant, or we don't think about it twice. But actually, when you lose something like that, you really understand what it truly means, and how blessed we are to be able to do things which other people might consider very simple. So I always like to highlight the COVID time to sort of really hone home that message. What exactly then is quality of life? How do you define it? If you ask one person, what matters to you in your life, and there's therefore lots of different considerations that you have to take into account. There certainly is the economic status. People consider wealth, or be able to be able to bring in wealth a sign of good quality of life. To be able to maintain that standard of living, certainly to be able to do that. Employment, right? So being able to go to work. Some people love work, some people not so much, but it has a meaning. And if they're unable to work, well, that matters for a lot of people. And that might link to the to career progression. It might link to certain aspects of career progression. For example, if you're a young teenager with really bad hand eczema, you may not consider dexterous professions because you can't use your hands. So some people consider employment as a defining aspect of quality of life. What about relationships? Relationships, of course. Whilst there are different types of relationships. You're talking about siblings, parents, intimate relationships. These are all important in different ways to us and is defined by our individual circumstances and how we live on a day-to-day basis. But certainly relationships come up often when you ask about people's quality of life. Again, going back to COVID, when you weren't able to meet the people you love, that was very difficult. I remember I couldn't see my parents for a very long time, and that was a very distressing time. And I was on the front line as well, so that meant I had to sometimes stay away from my own family. So and that's thankfully for me that was a limited time. But if your relationships are being impacted because of a chronic skin condition all the time, it's something to consider. And I'm mentioning about career, again, career progression. So not only is it about going to work, but how are you going to advance in that career? Your ambitions, what is it that you want to achieve in life? And whilst it's easy to come up with a list of things that you would like to achieve, ambition is really much defined within your personal circumstances, with what you feel like you're able to do. And certain conditions might make people believe or give the impression that they're unable to achieve certain ambitions. And that's really important. What role do we as clinicians, as dermatologists, have towards helping patients reach that ambition? And that's why I think it's a very important part of defining that quality of life aspect. Religion is a big one, of course. Practicing one's faith. People have different faiths. People have no faith, but it's an important part. People, I have seen many people with very strong beliefs who come into clinic, and they are very much affected from their faith perspective, that the things they want to do. For example, when you talk about the Muslim faith, and I've seen many patients come through the clinic where they're unable to wash, where they have to wash 4 to 5 times a day to pray. They can't because of how severe their eczema is. So what is the implication of that, and how does it make them feel? These are important considerations that really help define quality of life. So I've just given a couple of things here, that manage to define quality of life, that influence quality of life. All the way from economic status to work to ambition, personality, your faith, your expectations. These are all things that you can't really cover in a 10-15 minute consultation that you might have in your clinic. And so this is why capturing this information does become quite crucial. But how do you do that in a way that's going to be really meaningful, and in a way that's not going to, that's also going to be time efficient? So what is the definition that we use? The World Health Organization states it's a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So yeah, that's good. It's a holistic sort of approach to quality of life. But my favorite definition is a bit more diverse, and it's my favorite one. It's an individual's perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. And it's a very heavy phrase, but it's a very important phrase. What are we treating? I see patients who come in with a patch of psoriasis, a single patch of psoriasis, but it makes them absolutely miserable. Their PASI might be 1, but the severity might be just on the lower end, but they're absolutely miserable. And I see people who come who are covered in psoriasis, but they're very happy. They're happy to live with it, and it really generally does not affect their life. And so that's why I think placing the impact of a condition and the quality of life definition within their own expectations, goals, and standards, I think is really key and really important to consider. What are we treating, and what is our aim of our treatment? And I like to really divide quality of life impact into 3 dimensions. And this is what literature shows as well in terms of how generally it's divided. It's now. So how does your skin condition affect you now? How does your skin condition affect you in the long term? And how does it affect the family? So, these are important things that might help influence our treatment decisions. And and we'll see in the coming slides, it goes beyond just the person in front of you. You have to look at all these aspects of quality of life, because if you look at the impact of quality of life beyond just the patient in front of you, of course, they are the key, they're in front of you, but it gives you a holistic idea of the true impact of a condition. So let's talk about psoriasis, for example. Even psoriasis comes from psora. I appreciate this is probably foundational and quite basic for many, but I just like to break it down, because again, you can't really dissociate, you can't take away the quality of life aspect even from something like psoriasis, which is a very common condition. Psora is a Greek term for being itchy. So it's a symptomatic definition. It's not how it looks, it's how it makes a person feel, right? That's how it's defined. So it's a very interesting way to start to understand conditions, because how are their named is because of their and why we treat it is because of their inherent symptoms and their risks. And for many years it was grouped with leprosy. Again, that's important because stigma is a huge part of quality of life. A lot of and we'll see in the questionnaires later on that patients often are they feel conscious that people are staring, and children in particular are subject, unfortunately, to bullying and questions. And so when you have stigmas, like for example with psoriasis being grouped with leprosy, only when it later became differentiated, then then you sort of increase that understanding in a societal context. But that stigma makes a difference. We know about psoriasis, and that's why I'm going to use a little bit of psoriasis as a case presentation. And I just wanted to, for those who may not be familiar, just to quickly recap that these are silvery white scales that present in usually the extensor surfaces and can be itchy, can have involvement of the scalp and nails as well. A very, very common condition we come across in our inflammatory clinics regularly. And it's it's a worldwide problem. You see it in across the world, really. A lot of places we don't have the data for, but it's definitely more common, and the prevalence we know is prevalent in certain areas of Europe and America as well. But there's an issue with recognizing psoriasis on skin of color, and there's some excellent work being done in Manchester trying to highlight skin of color psoriasis diagnosis and actually better representation of the epidemiology there. But it's a widespread problem. We know over 125 million people suffer with it, equally men and women, and it can happen at any age. I mean, just today I saw a patient who was nearly 80 with psoriasis over the last 20 years. And so it is a problem really that affects all sorts of ages, and the incidence increasing over the last few decades. The challenge is there's lots of different clinical presentations, the different subtypes, and sometimes it can be quite challenging to diagnose. Sometimes it can be misdiagnosed, but there are different types of psoriasis. And again, this is just, I know many of you probably already know this, but it's just good to highlight again that the quality of life impact is different according to how it presents. If you've got a widespread psoriasis on your torso, compared to whether it's on your scalp, whether it's affecting your genital region, they all have different implications. Someone with the scalp might feel very conscious wearing black, like I am today, because they're very wary that the flakes might come down onto their clothes. Someone with genital psoriasis might have real issues with intimacy and relationships. And so that's why the subtype, it does matter. It's important to consider how might that, you could argue that for that patient, even though it might be limited in one area, they are equally deserving of real treatment, even though it might clinically not be severe overall. So it's important consideration. And this is the traditional way that we score psoriasis severity. I mean, this may be any condition, but we look at, but for psoriasis, we look at the erythema, how red it is, how scaly, and how thick the plaques are. And then we add it up in terms of the surface area. And we know that if the score is over 10, they're severe. And traditionally, you've basically had endpoints where you're trying to achieve a clearance of PASI 75, i.e. 75% clinical improvement, PASI 90% improvement, and sorry, it's under my camera, but 100 and eventually 100% clearance, right? So this is how we traditionally address severity of psoriasis. Now, if you look at the comorbidities, when a patient comes and sits in front of you, realistically, we only have 10, 15 minutes to talk to them. But we know that psoriasis is a chronic inflammatory condition, but it has a central element of metabolic syndrome where it can be associated with lots of other problems. Patients also suffer with hypertension, 42% with hypertension, 18% with depression, hyperlipidemia, diabetes, obesity, and of course there are other addictive behaviors associated with it. Stress, people get stressed because of their skin and they go into addictive behavior as a result. And then that addictive behavior sometimes has a negative impact on their skin condition. And that just becomes like a cycle that they're trying to break out of, but they can't. So I always tell patients that psoriasis is not just a skin condition. It's more than that. It's a central condition. It's a central inflammatory condition that's associated with a lot of these other comorbidities. But how do we then measure that? We've talked all about these things. How can you sit in a consultation? And I mentioned 10, 15 minutes all the time. I've said it a few times already, but how do you identify that in a patient who's sitting in front of you in clinic? How do you gauge that impact on their life? What is that ideal measure? And that's what we really want to try and use. So when you look at quality of life as a concept, one of the things that was coined in a couple of decades ago was the patient-reported outcome measure. So this is something that comes from the patient about a health condition or the treatment without interpretation of the clinician or anyone else. So it's not me as a clinician saying to that, putting words in the mouth of the patient, or it's completely unadulterated from the patient. It gives the patient's point of view, and that can include symptoms, it can include functional status, and general or health-related quality of life. So these are important things that would come under quality of life or the patient-reported outcome measure. And a lot of these changes were pharma-led. There was this increased sort of awareness of having this patient input in assessing the treatment. And I'd recommend people to read around the health insurance experiment, which is the impact of health insurance on outcomes. And it's a very interesting study. But generally speaking, quality of life has become more and more prevalent as a concept in all the studies. And now that's why a lot of the chronic studies you see, chronic inflammatory conditions and the studies on these conditions, you'll see a quality of life measure. And it's really based on this one simple concept, which is when you ask the same question often enough, you get the same answers again and again. And what do I mean by that? By that, I mean if you had 100,000 patients with a skin condition, they might have all different skin conditions. One might have psoriasis, one might have eczema, one might have skin cancer of some sort, one might have hidradenitis suppurativa, one might have male pattern baldness, one might have vitiligo. But if you ask them, all those 100,000 patients, one after the other, how does your skin affect you? And just tell me as much as you can. And if you keep asking enough people, eventually you'll find that the answer is the same and that you've asked all the questions you need to ask. and you're getting the same sort of answers after a while. And essentially, that's how a lot of quality of life measures are made and how they're sort of finalized. Over the last, this is one of the studies that we did in psoriasis, and it was looking at randomized control trials, and you can see that over the last 20 years, the quality of life instruments in psoriasis have generally increased. They've been on the up, and there's a reason why, and that's because, well, we'll talk about that. But what about the most common measures? Now, when we talk about looking at quality of life, you have general measures where it might ask generally about your life. You have derm specific, so the questionnaire would ask about your skin in general, and then you have the disease specific. So the disease specific would target a particular condition, for example, psoriasis disability index, or the psoriatic arthritis quality of life measure. There's a NAPSI, there's a scalp one, the Vitiquol is a vitiligo specific, but these are more really for psoriasis I've listed here. But what actually happens is the general is not as applicable to a skin condition, but it can be compared with other conditions, not just dermatology. So if someone with psoriasis fills out a general questionnaire and somebody with heart disease fills out a general questionnaire, there's somewhat of a comparison you can make. But the problem is, in each case, it's not very specific to that condition because the questions are generic. Whereas you start getting towards more specific questions, then it becomes more targeted at that patient, more relevant for that patient. But then the problem becomes where you can't really compare different conditions because you're using different measures. So the one that at the moment, and I'm fortunate to have worked with this department for the last 13 years, is the Dermatology Life Quality Index. And many of you may be familiar with this. This was developed about 30 years ago by Professor Finley, who's pictured here just above me. A fantastic professor. I've had the honor of working under him and learning from him. This is the most used quality of life measure in dermatology in the world. It's 10 questions. There's over hundreds of translations now, actually, and it takes only 2 minutes to complete. And it asks about your skin condition over the last week. How painful was it? How has it made you embarrassed? Has it affected your shopping? Has it affected the clothes that you wear? Does it affect your sports, your work, your relationships? Does it make your house messy? And does it affect your intimate relationships? So this was devised by having this sort of process of asking patients, until there were the same sort of themes coming over and over again. And it takes under 2 minutes really to complete. And it's asking about the last week, so generally over the last week. So it's got a 1 week recall, and now it's also been validated electronically. You can, I've got my phone here, you can download an app and patients can complete it on their phones. But it's not a perfect measure. There's been critiques of it over the years, whether there's not enough representation of the emotional aspect. So a lot of people recommend using a psychological measure alongside it. And of course, you can see that on the right hand side of the measure that there are some, and I'm just pointed here. You've got a not relevant section, and the not relevant section is for some people, for example. If the question asks me, well, over the last week, how much has your skin made it difficult for you to do any sport? Well, I'd tick not relevant because I think, well, I've never done sport, but that could be because of my skin. And actually that not relevant scores 0, which may not be an accurate representation because really they should say a lot because they never considered sport because of their skin. So there are some valid criticisms of it. There is also a children's version, which is while the DLQI is for adults 16 and above, this children's one is for age 4 to 16. Again, 10 items over the last week, and parents can help children complete it. Very, very similar questions. And there's also a cartoon version of it for children who might prefer that. Again, there are app versions of this that we've just released as well. This is an example of a disease-specific quality of life measure, which is the Psoriasis Disability Index, also known as the PDI, which is also owned by Cardiff University. Again, it is used a lot, especially for psoriasis-specific studies and psoriasis-specific sort of consultations, but it's more tailored towards psoriasis. Whereas, if you go back to the DLQI, it's more the first measure I showed you. That's a bit more generic. It's just asking, how does your skin do X, Y, Z? Whereas this question will ask, how has your psoriasis, etc. So, some people say, for example, that first measure is just not, for someone who has alopecia. Well, why, with hair loss, why are you asking about the skin when you've got hair loss? So, it may not, whilst it can be used for hair loss, absolutely fine, the DLQI, it may not always appeal to the patient, where something like the psoriasis disability index is a bit more specific. And let's talk about how, when you look at the studies about psoriasis, how does it impact a patient's everyday life? And you can see some of these, some of the answers here. Psoriasis affects, for most people, their emotional well-being. It's a problem in their daily life. I mean, imagine having the same problem every day. 94% people feel that, and 82% interferes with enjoyment of life. So not only is their emotional well-being affected, it's a problem in their life, and is interfering with enjoyment in their life. And that's an important thing, a very important thing to consider. What about the psychological issues? Well, 75% believe they have a moderate to large negative impact on their quality of life. And this is a really staggering thing to consider. A fifth contemplate suicide, and it's so easy for us to clinicians sit and, we're busy. We've got lots of things going on, lots of results, admin, and, we've got managerial pressures. We have to see as many patients as we can. But it's easy to miss, these small signs, but significant signs that might present in patients. And sometimes it just takes one question. Even if you don't have time to do these questionnaires, which are 2 minutes or 3 minutes, how does it make you feel, or how do you feel about it? These patients are more likely to be depressed and feeling hopeless. They're concerned about their future plans, and like they don't have any control over over their lives. I mean, that's a scary position to be, to feel like you don't have any control, that you're not in the driving seat. And as a result, patients have that, they have that feeling of humiliation, especially, and I mentioned, I covered the aspect of intimacy, and that's come up in my clinics many times. But things like swimming, I had a father who said he's never been able to swim with his children because of the humiliation. Again, there's a lot of and I think it's important to consider, there's this feeling amongst patients that the public and physicians don't understand that impact. And I think whilst we do understand it, we probably don't always relay it as well as we probably should. And counseling may help with the psychological and mental condition as well. So, I don't think we should underestimate the importance of counseling. There are some very good psychological support systems that we have in the NHS here, and just being able to talk to patients about their condition, how they can manage it, how they can address certain mental health aspects of it, can be really, really helpful. But having access to a clinical psychologist is quite difficult. But again, something to bear in mind. And again, I mean, this summarizes the emotional and physical impact of psoriasis. The blue is the no, does it affect these things? And the red is the yes. And you can see it affects most of these things. Self-consciousness, unsightly appearance, anger, frustration, embarrassment, clothing, concealing, summer or winter, they're wearing all the same clothes, covering head to toe because they don't want to enjoy the summer sun because they're too embarrassed to show their skin. Disfigurement, physical irritation. These are, imagine you have to live with that daily. We are blessed to be able to open our cupboards, just put on anything and just walk out the door. But sometimes for these patients, it can be a long, long journey to do that. And we talked about work, the work impact. 60% report missing 26 days due to psoriasis, and 35% report reduced earning potential. So this is huge because missing, I can talk certainly from an NHS point of view. We're trying to save the NHS here. There's lots of pressures, lots of there's lots of, unfortunately, critique of the NHS at the moment because of all the waiting lists and all of that. But, if you think about reducing that pressure, if you have somebody who's reporting, at least a month almost of missing work because of psoriasis, that's decreased financial income for them. It affects the overall economy of the country. It affects the wider implications, because if it's a child and they have to stay home, then that means parents have to take days off. So there's that cost of disease care as well, loss of productivity, career prospects. We probably patients are unable to chase certain dreams because of that. And so all of that economic impact, when you compare it with psoriasis, for example, is comparable to other chronic diseases. And if you consider this, then maybe we can see how psoriasis actually is the impact is much more beyond that patient that's sitting in front of you, and is great for that patient. It's a great impact on that patient, but it's a great impact for those around as well, and we'll look at that as well. Work life, limits in education, work, limitations improving job status, influence and skills to earn money, forced to quit jobs. I've had lots of this. I've had lots of people who come in and they just cannot work because of it, and both men and women equally affected. You can see here. What about the social issues then? What are the social aspects of quality of life impact? We mentioned about the maladaptive coping responses. Smoking and alcohol, these things, for example, can have a negative impact on psoriasis anyway. But if your psoriasis gets worse, you lean back on those addictive behaviors even more. And then what happens with body image? If your psoriasis gets worse, your body image and your self-esteem and your self-concept, these things get affected as well. And then that comes with the other things, like the shame and the embarrassment and the stigma. And it results in these unpleasant social consequences. So it's really important that that we understand these things. When patients also, they have different opinions about whether they want to discuss their skin condition. And often patients want to avoid contact with people. These things are significantly associated with a negative impact on their life. But if patients talk to others about the non-contagious nature of psoriasis, this lessens that negative impact of the quality of life on the quality of life, and reduces that social comfort. So it does empower patients when they talk to, when they say, look, this isn't contagious. But that's still there. People still believe that. They're afraid of that, and people naturally, unfortunately, have that sort of reaction if they're not educated on it. And this really brings me on to the greater patient. I've touched upon this. You've got the patient in front of you, but the patient who's around that patient, this is the concept of the immediate close social group who are affected by that person having a skin disease, and that's known as the greater patient. So there are measures for this. These are family reported outcome measures. At Cardiff University, we have the Family Dermatology Life Quality Index, but we also recently developed the Family Reported Outcome Measure, and this is the second one listed here. And I'd like to highlight this one in particular, the FROM-16. And the FROM-16 has been developed and is not just for dermatology, but can be used across all medical specialties. We've done work in multiple sclerosis. We've done it with COVID. We've done lots of different conditions, and it's validated across all medical conditions. Lots of great work has been done on this, and it can measure the impact of any condition on the family, and any family member can fill it out. But when you look at, for example, parents, what's the impact on the parents? If you've got a child who's got a really bad condition, a severe condition, skin condition, it can affect the parents' well-being. It causes stress for the parents and concern about the child. Sleepless nights. What happens if the parent is up all night? I've got a friend, and they're both actually friends. They're both doctors. They've got a young child, 6 months, who's got really bad, severe eczema, and they can't sleep at night. And then, to go function as a doctor the next day is very, very difficult. But to function in any job is very difficult if you're up all night. The sadness, frustration, especially if it's a chronic condition where there's no cure, and often there isn't a cure. We know with psoriasis there's no cure. You can keep it under control, but there's no cure. So these are things to bear in mind. But what about the hobbies and the finances? Of course, missed days at work, we've covered that, and the impact on relationships as well. So there is that wider impact, not just the child, but the parents as well. And then the family, the relatives, they also worry. They worry, because of the concern for their well-being. And what about other things like 30% report extra housework and daily activities? One of the patients today was telling me that their psoriasis, it sheds everywhere and they have to hoover regularly. It creates a mess. They have to sit at night and they spend hours applying their creams. And if they're not doing it, their family members are doing it. So the family member has to spend an hour giving that treatment. It makes the house messy as well, and it's very difficult. It has an impact on social events. I've had friends who've been unable to attend social events because of their skin condition. Very important social events that to them that they feel very frustrated that they couldn't go. What about sports, leisure, holidays? A lot of people can't enjoy holidays in the same way, and family and members cannot. When my father was unwell, he had heart problems and we couldn't. I remember we had booked to go away somewhere for a holiday, and he had heart problems and we cancelled it. And though it's you think, well, it's a holiday, but these things matter to people. These are little things, little enjoyments in life that sometimes you're blessed to experience, and affects the patient, affects the family. These are things that people care about, we all deserve lives that are wholesome in the ways that we want them to be. Siblings are affected, same sort of thing. What happens if you've got one child who's got psoriasis or eczema and the parents are giving all that attention, and the other child is not getting that attention? So what is that sort of, what are the implications of that? They can impact that child-parent relationship. It can increase that level of distress in siblings. But interesting, and the most interesting thing to hear is the point at the top here, that siblings can have a similar impact on their quality of life as the child with the skin problem, with psoriasis, and that's huge. They're not our patient. We're not seeing them in clinic, but they have that impact on quality of life, which means that has a wider socioeconomic implication. Definitely something to bear in mind. I remember recently asking somebody about their skin, and they said, it was really interesting question. They said it was the first time I've been asked about the impact of my wife. It was their wife's psoriasis, and it was the first time I've been asked about the impact of my wife's psoriasis in 22 years. So no one has spoken. The wife would be the one we see in clinic, but no one. Sometimes it just takes you to turn your head a bit to the right, and the person sitting next to them, and just seeing how they're doing. It's just it doesn't take that much time. It takes 10 seconds. Saying, how does it affect you, in the house? And, so these are important considerations that we can't always appreciate or always ask about in detail. But if we know about it, I think it makes us better clinicians. And there are positives, though. There are positives. And research shows that, for example, parents whose children have, for example, eczema, they feel a strengthened bond with their children because they're helping, treating, and supervising them. It develops that bond. They stop the children from scratching. But how do they stop the children from scratching? Have you ever seen a parent holding a child with eczema? They hold them tight, and they stop physically by cuddling them. They stop them from scratching. So that creates a deeper emotional closeness, and so parents feel empowered. Also by learning about atopic dermatitis and educating others. So sometimes these are some positives that people can feel empowered about their condition and feel like they can make a difference for other people. So that's a positive sometimes people take away. So really, this brings me to the end of the presentation. I mean, the key thing is dermatology isn't just about visual measurement. Quality of life measurement is vital for insight into burden of skin disease. Absolutely. You cannot really understand the impact of a disease unless you know how it affects someone's day-to-day life. There are generic measures, there are specific measures, and it's absolutely up to the clinician or the context on which to use when. I do use the DLQI, and I am biased because it's the department I work in, but it is the most commonly used measure in the world, and it's easy, it's quick, and I recommend introducing that if you don't in your general clinic. Some things we have to, because now it's so important. These quality of life measures, they're embedded into guidelines, they're embedded into registries and things like that. So it makes a big difference. But this will help us understanding quality of life, and the impact of quality of life will help us understand the wider impact of disease, the economic impact, and how it impacts careers and lives. That means we can give more tailored treatment. That means, patients may get treatments they otherwise would not, because we might simply disregard it as mild severity from a clinical point of view. But it's not just about the clinical appearance. It's not just about visual measurement. It's not about necessarily just clinical severity. The greater patient needs a greater therapist, right? So you've got a patient in front of you, and then you've got a clinician. But if you look at the greater patient, you need to be the greater therapist. And that's why we need to really develop the quality of life science. Thank you very much for listening, and I hope you found that informative and a quick introduction to quality of life. I apologize if some of this was something you already knew, or or nothing new for you, but I think it's always good to highlight these aspects of skin condition, but not just dermatology, but I think across the board. I think this is applicable to all medical conditions, all health conditions, all sorts of problems in life. I think having an approach, a holistic approach, is always a good thing, because I think it makes you more understanding, more empathetic, more sympathetic to the patient, and you display more empathy and understanding, and the patients appreciate it more as well, and that means you can give more holistic care. Thank you for watching, and I'd be very happy to take any questions.
We're just gonna move to the last item on today's scientific conference, the sessions that we've been having, and that is the panel discussion. Following all those enlightening lectures, I would like to call on the following doctors to come up here with me so that we can do this final activity. So our panel discussion is gonna center around the theme, every second count, strengthening critical and emergency care in Africa through local solution. It's going to be our theme for discussion this evening. I would like to start with Dr. Hamed Hassan. How can pediatric emergency care be strengthened, especially for life-threatening conditions such as sepsis, severe malaria, and trauma?
Good evening, everyone. Like I said, how do we strengthen pediatric emergency? I won't say, I'll be speaking in the aspect of as a pediatrician and working in a low resource environment. How do we strengthen this? I'll start with the fact that when we talk about, I always believe that people have a lot of knowledge. It is the attitude that really matters. So starting from this, I would say the first thing is to decrease intra-facility delays as much as possible by doing what we call triage, having a good triage system, a functional triage system. Indirectly, meaning that as much as possible, triage people based on the clinical signs. When patients are based on the types of how sick they are, or the likelihood of them surviving, so we put them forward ahead of the others. Part of this in terms of reducing delay is ensuring ensuring that clinically and critically sick patients are given first and taken to the emergency room. The second way, I'll just try and highlight them. The second way is preparation for resuscitation. One of the ways, because based on the sepsis, severe malaria, and other trauma and other things, my house officer once told me that anytime we admit patients into the ward and we resuscitate them and we give them adrenaline, they'll eventually die. When you resuscitate, that's what we noticed that they immediately died. Why do we go ahead and do that? And I told him one of the things why they die majorly is because of lack of preparation. So I told him on Monday, get everything ready. put everything together and don't wait till the patient, maybe they start gasping, let's start all over. And for that 1 week, there was no death, no single death. And we had those kind of cases. And I asked him on Friday, why do you think we have this? He said, I think it's because of preparation. Because of lack of preparation ahead of things. At times you find out when emergency comes in, we are still looking for the ambu bags. Where are the drugs? Are they well delineated? Where are the IV fluids? Where are the other things, the oxygen, everything being available? Having a clear assessment and algorithm for management of patients is important. And one of the things I try to do, as being a consultant pediatrician, I'm a neonatologist now, working as a neonatologist, in charge of a course called post-basic certificate in neonatal care. So one of the things we try to do is to ensure have clear-cut clinical algorithm in management of clinical condition. Let everybody be aware of this as simple as possible. You find out that 80% of cases will be managed easily by these healthcare practitioners. Before, only 20% or 10% will get to my level. So, okay, we need your intervention. So if everybody is aware of those things, it makes things easier. And that's based on common clinical condition. For example, interventions, line setting, and trying to do all those things. The third part of it is empowerment of staffs and with clear supervision, ensuring that the nurses, you don't have to have the doctors, everybody. Have specialized care, try and take them at the basic level. The nurses themselves, how do you do the random blood sugar? I mean, when it's low, what do you do immediately? At that point in time, what are the basic things you can do? And I can boldly say it. I have nurses who are SHN nurses or SRE nurses who can do intravenous line setting, who can do umbilical catheterization, for newborns. And this is empowering them, ensuring that they can get to a particular level, supervise it, and ensure the skills are well done. And maybe I'll just say, because of time, then intersectional collaboration. You don't believe that you are alone. You work as a team. Once in a week, we must have a discussion between the doctors and the pharmacist, the lab scientists, and other segments, the clinical CHOs and other things. Let them know what the problem is. What do we have now? And we plan based on seasons. During the dry season, I know I may have cases of burns. I know I may have cases of asthma, exacerbation of asthma. During I know I may have diarrhea occurring, which will come with severe dehydration and shock. I want to have IV line, intravenous lines materials available. I want to have other things ready. I want to know from the pharmacist on Monday, what do we have? What are the constraints we are likely to have? Because you can't be a consultant in it, everything still fall back on your table. So you must plan ahead of all those things and work as a team. And let me say, human capacity development, which I've mentioned initially, we have, I'm just trying to be as practical as possible. Training people, especially. As a lecturer in both undergraduate and the postgraduate level, there's a master's program going on now, pediatric and neonatal nursing, which I'm like the coordinator of the program. One of the things we try to do is ensure that everybody is capacitated, ensure people have the basic knowledge. If they have that, people are independent. We have regional hospitals, we have district hospitals, we have primary health centers. Be there, and as much as possible, training which is not just, I don't believe in training of calling people into the all. I believe in on-job training and mentorship. Ensuring you are there, mentor them, give them some level of independence. Don't do micromanaging. Thank you.
Thank you, Dr. Leroy. Talking about that training and educating and awareness. Dr. Kumba, how can public awareness campaigns and community engagement improve early recognition of medical emergencies and timely access to care?
Thank you for the question. I believe that public awareness and community engagement are central in strengthening emergency and critical care in Africa. In many of our settings, people tend to present late to the hospitals. This is because they cannot spot out or detect danger signs early because they are not aware of these things. So these signs can range from a child with severe dehydration, a mother that's bleeding, postpartum hemorrhage, or someone that presents with signs of stroke. So these things are not picked up quickly. So there is a delay in seeking help. So public awareness and public awareness campaigns that are culturally tailored and delivered in our local languages, I believe will help solve these issues. For instance, in the Gambia, we see a lot of patients that are asthmatics. So, and they refuse to get nebulizers, inhalers. This is because some of them believe that this can cause an increase in the severity of their symptoms, or they become dependent on the inhalers. So they sit home and wait till the symptoms get worse, so they present to the hospital and only accept to be nebulized in the hospital. And it's the same drug, essentially, just in a different form. So this shows that the awareness is lacking. And the myths and misconceptions and stigma sorry. So this shows that the myths and misconceptions delay life-saving care. But when we take our time to educate and engage with people through radio shows, visiting schools, or through the community or religious leaders, I believe people will seek care promptly as needed. Community engagement also builds trust. When people are engaged, involved, and informed, they are more likely to seek care when needed. But this also goes hand in hand with system readiness, because you cannot prepare people and teach them everything they need to know to seek care. And when it's time to get to the hospitals, it's a problem. Or when we have emergency units that are not properly equipped and personnel that are not well trained. So this should be put in place. These measures should be put in place so that when people pick up these signs and come to the hospital to seek help, they are attended to and their problems are solved. Thank you.
Thank you, Dr. Kumba. I will move on to Dr. Kiprono Gidon. Both Dr. Kumba and Leroy mentioned two emergencies that they face, being it Dr. Hassan and Dr. Kumba, right, mentioned two emergencies, being it asthma, I believe, and dehydration. So what are the most common emergency and critical care challenges that are faced in hospitals common in Africa?
Okay, thank you so much. My name is Dr. Kiprono, and I'll be talking about the most common challenges that is faced in our hospitals. And I'm happy that throughout the day we've been talking about critical care, and some of the challenges were highlighted in the presentations. So I'm going to talk about some of the challenges that we see. And it's very important to understand that every second counts, because almost the last presentation we were talking about time is brain, time is muscle, because if we delay, we might have adverse outcomes. We talked about the golden hour. There's also the golden minute when we are talking about neonatal resuscitations. There are different emergencies covering different systems. Now, looking at the different challenges that are faced across African hospitals and communities. The first one, we have weak pre-hospital care, and we have also challenges to do with transport system. When we were coming here, it's interesting that the lighting was poor towards where we are staying, and apparently it's because, I don't know if talking about this will give me problems, but let me say generally, that the transport system in African countries sometimes lead to poor outcomes because the roads could be inaccessible, or there could be challenges to do with ambulance. There's also a role for bystanders. Sometimes they worsen the situation instead of helping. So I think there is need for education so that they understand in case of an emergency or a traffic accident, what they need to do. And also there is a limited critical care infrastructure. talking about ICU beds or ventilators or reliable oxygen is one of the challenges that we've seen cutting across. There's also shortage in terms of healthcare providers or staff attending to these people. And sometimes when they are healthcare providers, they could be having a gap in terms of knowledge. And I'm happy that Merck Foundation is trying to bridge that gap in empowering people to be knowledgeable in different specialties. So different governments have to work on the issue of healthcare providers. There's also issue which was mentioned to do with a lack of consumables or poor equipment, maintenance, and what have you. Sometimes emergency medicines are missing, or you could be lacking oxygen, and it's an important thing during emergency. So these consumables should be looked into to at least help in having good outcomes. And another thing is financial barriers and governance. People in emergencies, many people do spend out of pocket, or there could be, some have insurances, but they are limited. And we have to understand that critical care is very expensive, and people need to have access to referral services. So all these things are most of the common challenges that we see in our setups, and it cuts across. Thank you.
Thank you very much. And I have to agree with you in that healthcare is not cheap and it cannot be free, which is something that most of the politicians, the governance systems within Africa, that's what they always preach. We're going to give you free healthcare. We're going to give you free healthcare. When it's free, it cannot be quality. So you have to pick one. Either you pick free and you die, or you pick payment and you stay with us for a while. So we need to start putting that across. And I think they have to be more honest with the population as well. So yes, based on what you mentioned, you did spoke about the first responders, how they're going to be having emergency care from the beginning, being the ambulance services or whatever it could be. So I'm going to go to Dr. Amma next to you there. Hi, Dr. Amma. How can community members, first responders, and caregivers be educated to recognize emergencies and seek help promptly?
All right, thank you for the question. So in emergencies, there are three things which are important. First, the recognition of the emergency, early response, and then timely access to health care. Here on our continent, where emergency systems are still developing, we have peculiar challenges, as have been mentioned. One of my friends who is an emergency physician likes to say that the first person who sees you in an emergency determines whether you live or die. And really, time is of the essence. Every second really counts. For instance, in my country, Ghana, and I think in Nigeria too, because I see them in Nigerian movies, if someone collapses, the first thing that is done is to get water. And it could be anything from sprinkling water in your face or pouring buckets of water in your face. And we are forgetting or don't even realize that we are blocking the patient's airway by doing that. Someone slumps and we think that, oh, he's very ill. This one needs to go to the hospital. But before he goes, let's feed him something. So they may have had a stroke, but they feed them porridge or only God knows what, so that when they get to the hospital, you have to eat for the medicine to work, right? And then the stroke patient comes in having aspirated from his house, and it's the aspiration that kills them and not the stroke itself. One more example, someone is happy dancing in church, and all these are people that we have seen, like I have seen happen in the ER, dancing in church and then slumps. And they think, oh, something must be happening. This is spiritual. And we pray for the sister or brother. Then we carry them home. And then next day, they are not really better. They seem to be weak somewhere. And it's until then that they come to the hospital. Your thrombolysis and all the highfalutin things you could do, time has passed. So these are the realities that we live in our setting, so that the first person that sees you in the emergency is your neighbor, your classmate, or your colleague at work. And that is why tackling this from the community level becomes extremely important. We've mentioned a lot of these. Implementing them is what becomes challenging. Education is key. Of course, we must know that don't pour water in the person's face, the one who has collapsed. Don't pour water in their face. And for it to get down, we have to actually say it in a language that people understand. Simple, small languages. Maybe form some slogan. Don't pour water in my face or something, whatever. But it has to be simple enough for people to be able to understand it in their language and be able to implement it. So education is fundamental. However, it's going to be, there are several avenues. We've mentioned the mass media, etc. Now, another thing is first responders. In Ghana now, the government is training 6,000 first responders, or that is the goal, countrywide, so that we bridge that gap between the community and the hospital. Then there's somebody who potentially knows what to do in your community and saves you from getting that water in your face, perhaps. Okay, so that becomes important. I'm sure other countries are implementing similar things, or they may learn. When we've done all of these things, communities must own them. It must be sustainable, so that we don't start and then in the middle we give up. Okay, so getting community leaders involved so that they own the programs and help it to run. And then we must also assess what we are doing. Is it really making a difference? What are the pitfalls? What have we done right? What have we learned? And share it with others so they can also build on what we have all started. I believe that these are some ways that we can make a difference.
Thank you, Dr. Amma. Thank you. Like you mentioned, there are other countries also doing it, and I believe Tanzania is one of them who is doing so much when it comes to emergency care and getting first responders and all of that into their system integrated, and which is good. I hope one day all of us will get to that level. You also mentioned some of the traditions that we have of pouring water and all of that. And Dr. Kumba also mentioned myths and conceptions that he sees facing here in the Gambia. I would like to move on to Dr. Sair. Dr. Sair, can you please tell us what are the main barriers to accessing emergency services in low resource settings and how can they be addressed?
Yeah, thank you very much. So there are several challenges or barriers in accessing emergency services, especially in low resource countries in Africa. And one of which is lack of funding. Lack of funding. Most of the times patients pay out of pocket and it's expensive. Healthcare is expensive. We also have, of course, we don't normally have insurance in most low resource countries. And another challenge that is actually been faced is also geographical challenges. In Africa or in most settings, we have hard to reach areas. Like from where I'm coming, we have mountainous areas and the road network is very, very deplorable. So to access emergency services in such areas is extremely difficult. And we can also have riverine areas, you know. And another challenge is cultural and social barriers also. And of course, we can also have a lack of education, infrastructural challenges like lack of hospitals, emergency medicines, equipment, etc. Yeah, thank you.
Thank you. So in summary, it's basically each of your questions is answering the other. And it's like the challenges in Freetown, in Sierra Leone are the same in the Gambia, are going to be the same in the Ghana and anywhere else. I think in Africa right now, especially if it's talking about our sub-region here. So we're going to have similar problems. I want to move on to Dr. Leroy. I mentioned you before, but I didn't ask the question. In what ways, we are talking about multidisciplinary, we are talking about integration, and we are talking about collaborations a lot. So in what ways can pediatrician and internal medicine specialists collaborate, improve integrated emergency care for both children and adults? Because in most settings, you're going to find probably you're not going to have a pediatrician. You might have only one physician who is a general practitioner. So there should be a system or at least some basic knowledge that they are been able to manage both pediatric and adult cases, which is what we have in most of the places or most of the health care facilities within our sub-region.
So I'm mostly going to speak from the internal medicine perspective, and I'm a bit biased because I work at a national referral hospital in Liberia where we have specialists, both internists and internal medicine. But I think it boils down to education, the same educating the first responders, just in case you don't have those specialists in pediatrics or internal medicine. And in my experience, when the neurology clinic, there have been times where I've had referral from pediatrics, especially regarding seizures and epilepsy. So you are right. I think there should be a continuum. So how we can go about it is this. So I think it all starts from the clinic. So most of these patients that will have these conditions that they might live longer with, and then transition into adulthood with, I think there should be a system in place. When I was undergoing my training, we used to have rotations where you have some 1 month, 2 months rotation in pediatrics to see how you care for those patients. Because we see the little kids as we call them little people. So the same problems, they have the same problems as the adults. So I think it's from the clinics, we follow them up. So initially they are worked up by, they are followed up by the pediatricians, and then as they get older, in my hospital, we start seeing them after 15 years. So initially they are seen by pediatrics, and then over time they get transition to internal medicine. So I think it's just constant, or it's just communication, because most of the management is almost the same. It's just that the difference is for the pediatrics, you have to calculate a lot of math. You got to give medication based on the weight. But I think the same principle applies, just education. So I have to teach the first responders in cases in areas where you don't have specialists and consultants, and then keep continuing medical education, keep training, keep creating awareness, and then that's one way we can go about it.
Thank you, Dr. Leroy. And you mentioned about like you're going to be biased. You're going to start with internal medicine because that's where you're rotating. And I don't know whether it's only in the Gambia, but we have always this feud between internal medicine and pediatric. No, it should be under pediatric. No, it should be under internal medicine. So I hope by the time we are doing that back and forth, at least we have stabilized the patient. The patient is okay for. Then we can decide which department will host the patient or keep it. I hope I don't think Fatima will be happy. Dr. Fatima, are you happy? You're not happy with that, I know. You can't be happy. This way that you just become biased to adults. Absolutely not. But thank you very much. I understand, and it actually happens in all the regions. In most of the teaching hospitals, you have that back and forth of the patients, and even surgery and the other departments as well will be fighting patient care because we are all overwhelmed. So I get the system itself is the one creating that toxic environment where we are like pushing the patient from one doctor to the other. So I'm gonna go to Dr. Kitabu, Dr. Kitabu Jame. All these things that we mentioned about the healthcare system, how to improve them and all of, we wouldn't be able to do them if we don't know what are the data, what are the problems, what percentage of it are having. Today, they mentioned HIV burden of 15% in pediatric cases, and which was contentious. I had to contact the National AIDS Control Program in the Gambia to check on that. And they were like, the data, it's a long time ago, it's not now. But what helped that? Because there is research continuous going on. So if we stop research, we wouldn't be able to get this data, and we wouldn't be able to make policy making decisions that are going to really impact our healthcare. So how does effective data collection, monitoring, and research in emergency and critical care contribute to shaping evidence-based policies, and how can these processes improve and develop our interventions better? Dr. Kitao.
Thank you very much, Dr. Awa, for the question. Yes, for acute practices or acute medicine, we are the first responders in our facilities. Let's say for the healthcare landscape for a place like the Gambia, when people are seen at the primary facilities, they are seen, if they are not able to manage them, they send them to the secondary facilities. And then what happens, there is this delay, for which some of my colleagues have mentioned. That delay in care usually affects the outcome of what we get when we come to completely manage the patients. So when it comes to the Gambia, let's say when we have our patients visit us in our facilities and they come, forgive me 1 second. Yeah, so when it comes to the Gambia, forgive me, I don't know what's going on. When we see these acute conditions, they come, we manage them. I did an MSc in acute medicine. I was classmates with Leroy Yankee from Liberia. So for acute conditions, when they present to our facilities, we see them, we manage them, we have good outcomes. It is satisfactory for clinician to manage a patient till recovery, and then you discharge your patient. This is very satisfying. So what happens, let's say, for certain levels of care in the Gambia, let's say you're working at a secondary facility or a general facility, wherein certain specialists is on the ground, you have to stabilize your patient and refer to maybe to the teaching hospital. So this even also presents or accounts for delays when it comes to the management of that patient. So when they get to levels like that, also what they do for the patient is very important. And what we do for our patients, we have realized over time, record keeping is very important. For all of our facilities, record keeping is key when it comes to knowing what we do for our patients, being able to assess and evaluate the work we do for our patients. So record keeping is important. I remember a period in medical school, that was about 11 years ago, when I wanted to do a study on mastectomy. So I went to the records office of the teaching hospital, told them I have a study idea in mind, and they told me, yes, our records are available. So I started doing my study, but in the period I wanted to look into, they didn't have the sufficient amount of data I needed to give me the statistical power that was relevant to show some good impact from my study. So I had to extend the period. So for us as clinicians managing patients acutely, it is important we have good data entry of our records. So right now we have in-paper records or paper recording at some facilities, but we've realized that on certain facilities in the country or in places like the Medical Research Council, electronic records are being used now. So this is something that is very helpful. Once we are able to adequately record all the information of our patients, anytime ideas come into mind, we can go into these documents or go into this data and bring out adequate information that can guide policy when it comes to our healthcare systems. So something was mentioned here, which is the golden hour. Oh my, I don't know. Forgive me. I don't know what is going on right now. Forgive me. I don't know. Maybe I'm tired. This is not Kitabu.
It's a long day.
Yes.
It's understandable.
Yes. So what happens when it comes to research? Let me focus more on research. So we see our patients. Research is very important. When we see these patients, to guide policy, to guide decision makings, the work we do has to be presented in a way that is convincing. And this is why we get to do a lot of research work. So for the Gambia, research is something that has been ongoing for over 80 years with places like the Medical Research Council. And it is important as clinicians, we bring out data that is new, data that is convincing. I remember in Dr. Fatima's presentation in the morning, she mentioned doctors or clinicians like talking about prevalence all the time in their research work. So prevalence is important, but we should attempt to go outside things like just the prevalence of conditions. I also remember a discussion I had with the provost of our medical school 11 years ago when he was showing concern about people just doing CAP studies all of the time, CAP studies. So this was even something that inspired me to come up with 5 topics which I presented to my supervisor, something away from CAP studies. So as we manage our patients, it's important we document our data. It's important we collect this data, and when we evaluate this data, anything can be written and anything can be very substantial. Sometimes just a simple case report can show many things that are very beneficial for all of us. So you can have your patients come to your clinic. The patients you see in your clinic as retrospective cohorts, you could collect that data and write something very strong that the world can see and what the world can benefit from. Patients you also see and follow up on. This is something we can have all with us, and then I think that's.
It's fine.
I don't know.
It's fine, Dr. Kitabo. Thank you very
Okay,
much.
man. Oh.
We all know the importance of research. I know not the whole of Africa, but probably Gambia, we are a little bit behind when it comes to research. But I'm sure we'll catch up because, like he mentioned, most of the work is done by the Medical Research Council. And that one is like, it's not nationally guided, and most of their data might be used for other places and not just the Gambia. And talking about the collection of data and having information, we have the information system. It's called the DHIS2 in the Gambia that we use. I believe what we can do is to improve that system. The DHIS2 is capturing mostly HIV, tuberculosis, and malaria. So I guess if we open it up further, we will be able to integrate other illnesses or other conditions into the system, and this will help improve and make it easier for the next person who wants to make a research, be it retrospective. That way you will get your data easily. Thank you very much. So finally, but not the least, I'm going to go to my brother from Rwanda, Dr. Samuel. Dr. Samuel, right now, yeah, the boss is a lot on East Africa, Tanzania, Rwanda. You guys are doing so much when it comes to like moving your health system forward. So my question is, what's the difference in emergency presentations among children versus adults, and how can healthcare workers prepare for both in your settings?
Thank you so much, Doctor, for the question that you've asked. As you've said, I'm Dr. Sam Rutare, coming from Rwanda, and I work in University Teaching Hospital of Kigali. Well, I think I'm a true East African because I was born in Uganda, did my primary education in Uganda, then went to Rwanda, did my second education, a bit of it, then university undergraduate in Rwanda, then my postgraduate training in Kenya. So I think I'm much more of East African, as you said. Yeah, coming back to the question, I think the difference between the adult and the adult and the pediatric emergency care in East Africa or in Africa Traj is not very different, only that the presentation will differ from children and adults. Yeah. Maybe also another thing that will differ are diseases that are most common in children and in adults, because in children you expect to have diarrhea diseases to present in pediatric age group, presenting in dehydration and in shock compared to adult medicine. And another difference that is of note is the different vital signs. Different vital signs, what do I mean? In the children, different vital signs, that is respiratory rate, cardiac rate, the heart rate, will differ from different age groups. For example, in a neonatal period, that is up to 1 month of age, if the heart rate is 150 or 160, I will not be bothered. But when I have a child who is a child of maybe 4 years old or 5 years old and the heart rate is 160, I will be much more bothered. And when it comes to adults, then a heart rate of 160 is much more alarming. You can imagine this. Blood pressure of 120 over 70 in a 4-year-old child basically is an emergency compared to when this child is 14 years old. You understand? And in adults, it would be normal. It would be taken as normal. Another thing that I can comment on are different scales that we do use in assessing newborns or even children. The CNS assessment is different. In children, we tend to use AVPU, and then for older children, Glasgow Coma Scale can apply as well. But in the neonatal period, you have to consider using or examining the neonatal primitive reflexes to assess the CNS function of the newborn. Another point that I can also comment on is the IV fluid management in the pediatric age group and in adults. I think in adults,
they are not much more conscious when using IV fluids compared to neonatal or pediatric cases. With the pediatric cases, when it comes to IV fluid usage, you have to do it in a conscious manner, because the moment you give too much of it, you'll be causing chaos, and there will be poor outcome of a patient. And maybe another thing that I noted was DK management in the pediatric age group. You have to be very conscious when you are giving IV fluids. It's not giving a bolus of 15 or 30 mils of 20 mils per kg per the 30 minutes or 15, like in adults. But in pediatrics, it has to be over at least 1 hour to 2 hours. So if you receive a patient who is in DK, as we have talked much more about diabetes here, and you give much more fluids in a little time possible as you are used in adults, the poor outcome is expected. So please, when you're managing pediatric cases, always consider to be conscious when you are giving IV fluids. We did a study in our hospital where we tried to demonstrate that when there is good collaboration between healthcare providers, the outcome is always better. We tried to use these pediatric early warning signs score. You all know that it usually includes the heart rate, the respiratory rate, and even the CNS and the oxygen usage in the pediatric age groups. So this score will predict that this patient who is deteriorating because he needs much more oxygen, the respiratory rate is worsening, the heart rate is increasing, and you intervene timely, as my colleagues have said, the prognosis will be better than when there is no intervention. So please, when you are always managing children, consider always to have this pediatric early warning score to be in place so that it does predict and intervene timely.
Thank you.
With that, I thank you so much.
Thank you. Thank you so much, Dr. Samuel. And with that, we are going to close the panel's discussion. Once again, a round of applause to our wonderful panelists. Yes, thank you very much.
Just bear the videos.
So, as part of the closing, we would like to remind you that we have 44 programs in the Merck Foundation Capacity Advancement Program, and these include the programs that you have all applied to. So, and these programs are offered in the University of South Wales, Buckingham, Edinburgh, Cardiff University, Queen Mary University, and the like. So we also hope that you would have the chance to look at to download the Merck Foundation app, both on the Apple Store and Google Play Store.